Well, good afternoon and welcome everybody to this workshop focused on nurses and antimicrobial stewardship. We're all very, very excited to have you here this afternoon. We have a great group of presenters from multiple disciplines that we'll be introducing to you as we go through the afternoon. Of course, we've got nurses here presenting, but we also have two pharmacist colleagues and an infectious diseases colleague with us as well. Sorry, I'm just closing a pop-up. So we're very, very excited to have you here. But before we begin properly, I would like to acknowledge and pay my respects to the past, present and future traditional custodians and elders of this nation, and also the continuation of cultural, spiritual and educational practices of Aboriginal and Torres Strait Islander peoples. And I would also like to extend my respects to Aboriginal Torres Strait Islander people who might be joining us here today. A little bit of housekeeping information for you, and not in any particular order of priority. Throughout the session today, you are in what we refer to as webinar format. So that means that during the session, you will be muted and your cameras, you're not visible to us. However, at times there may be opportunities for you to ask questions, either using the question and answer feature at the bottom of the webinar screen. And also there may be opportunities, time allowing, where we will enable you, or we will be able to let you speak so we can hear your voice and you may be able to ask questions verbally. Also, you have at the bottom of your screen a function, the question and answers, as I said, and I'm pretty sure you'll have a chat function there, so you can put questions or comments, and we will be doing some interaction during the afternoon to find out where you've come from today, plus a few other questions we'll be asking through each presenter's session. So lots of opportunity for interaction. We will also be using what we refer to as the poll feature during this session, and that means from time to time there will be a question that pops up from the presenter of a session where you can put your answers in. We're not collecting answers from individuals. Your individual answer won't be identifiable to us. It's really a way of trying to gauge interaction and help you reflect on your learning as you go along. Now, I think that that's the main housekeeping information that I need to share, and I have colleagues here with me today, Dr. Courtney Irano and also Dr. Arjun Rakoa, sorry, and they're assisting me with some of the technical aspects of this day. So if there's anything that I need to add, I'm sure one of them will let me know right now or give me a little wave of their screen. I'm not seeing one at the moment, just making me feel happy. Okay. All right, so I'll just move on to some of the reason why we're here today and checking my time. So we're here today to talk about antimicrobials, and I've got here on this slide antimicrobials and a little bit about antimicrobial resistance. But really what we're talking today about is caring for people who have or are experiencing symptoms of infection, and how we provide nursing care to those people and how we work with our colleagues to do that, and how we work with antimicrobials when they might be needed in an appropriate and safe way. So we just thought we'd start, or I thought I'd start by just giving some reminders about what antimicrobials are, what we're talking to when we talk about antimicrobials. As it says there on the screen, we're talking about all medicines that are prescribed to prevent or to treat infections which are caused by microbial pathogens. And of course, this might include antibiotics for bacteria antivirals for viruses, antifungals for fungi, and antiparasitic agents. And of course, we all know that used appropriately, antimicrobials are absolutely essential and life-saving medicines. But they may also cause harm. They are associated with the potential for some adverse outcomes, which may include, for example, toxicity or allergic reactions. And they are also associated with the very significant problem of antimicrobial resistance, which refers to when subpopulations of an individual pathogen change to protect themselves from the effects of antimicrobial drugs, which may be designed to destroy them, or where they can resist the effects of an antimicrobial, so that the antimicrobials we have that may have worked previously don't work as effectively. Okay. And this slide here, which is a slide that I've taken from the 2021 Commission Antimicrobial Awareness Week PowerPoint presentation. It's an excellent slide which gives us a good visual idea of the impact of antimicrobial resistance, and in this case, antibiotic resistance, and how antibiotics can benefit individuals, but there are some consequences that it can affect communities and broader populations. And here I've just got some figures from the O'Neill report, which was published in 2016. The reference is at the bottom of the slide. In that report, it was estimated that 10 million lives a year were at risk from the problem of antimicrobial resistance, and a significant economic output as well. And at that time, it was estimated in 2016 that around 700,000 people each year die of resistant infections. And I'd like to refer you to a paper that was published earlier this year in The Lancet by a group known as the Antimicrobial Resistance Collaborators, led by Christopher Murray, where they looked closer at and estimated the global burden of bacterial antimicrobial resistance. So that has some further updates on what that might look like. And I haven't gone into detail here because of time, but I refer you to that paper for further reading. Now, antimicrobial resistance has been acknowledged, if you like, and incorporated into the Global Sustainable Development Goals. Again, the reference at the bottom of this page. There are 17 Sustainable Development Goals, which were developed by the United Nations, that focus on the need to end poverty and poor health generally, and poor living circumstances. And as it says here on this slide, it acknowledges here that any of these efforts to end poverty or other deprivations have to go hand in hand with strategies to improve health and education and reduce inequality, all while tackling climate change and preserving our oceans and forests. And with regard to the Sustainable Development Goals, often antimicrobial resistance is linked to the Sustainable Development Goal of good health and well-being, but of course it links to others that are mentioned here. For example, goal number 6 and goal number 14, and there's another one and I'm not looking, but I can't see it there. But I think the other thing for us to remember, responsible consumption is the one I'm thinking about. The other thing that it is important to remember here in relation to antimicrobial resistance is that people from lower middle income countries and communities are really at greater risk of problems associated with antimicrobial resistance than some others are in other parts of the world. So I guess we bring this in here to consider that while we are today talking about antimicrobial stewardship and the nurse's role in an Australian context, it's important to remember that we are part of the global community and there is a bigger picture here. Now, some priorities to address antimicrobial resistance include optimising antimicrobial use through stewardship, improving infection prevention control, improving laboratory capacities, surveillance of antimicrobial use, antimicrobial resistance and healthcare associated infections, and of course education and awareness raising, not only of health professionals but of communities and consumers as well. And all of these priorities, they're not, I haven't listed them here according to the chapters in this document, but they are discussed and outlined in Australia's National Antimicrobial Resistance Strategy. And that is available at www.amr.gov.au. That's the title of the document there, and I'm sorry I've omitted the reference from that slide, but you would be able to find that easily through a search. I'd also like to point out here the AURA report. AURA is Australia's national surveillance program for looking at antimicrobial use and antimicrobial resistance in Australian health settings. And if you're not familiar with this document, you can access it at that webpage at the bottom of the screen. This document points out that in Australia, we do still have high comparative antimicrobial usage in this country. You can also see that there is some variation in this country with the way antimicrobials are used across different hospital settings, across different states and territories, and also across different communities. So the AURA report covers antimicrobial resistance and antimicrobial usage in primary care, aged care and acute care settings as well. If you're not familiar with this document, then I encourage you to go and look at it to broaden your understanding of the bigger picture of the problem of antimicrobial use in Australia. But talking about antimicrobial stewardship now, antimicrobial stewardship really refers to complementary activities to guide appropriate antimicrobial use. And the objective is, often we talk about improving antimicrobial use, but actually the objective of antimicrobial stewardship is optimising patient outcomes and patient safety through evidence-based practice in managing infections. And all of this relates to minimising patient harms that may be associated with antimicrobial use, which of course includes antimicrobial resistance. Now, just to summarise, appropriate antimicrobial use refers to when antimicrobials are given only when indicated, for the optimal duration, at the optimal dose, the optimal choice, to the right person and via the right route. Examples of antimicrobial misuse, conversely, are when antimicrobials are used when not indicated, for too short or too long a duration, too high or too low a dose, too narrow or too broad, or when perhaps given via the wrong route. I've put here in, the intravenous when they could be given orally, but also perhaps we do hear of occasion when things are given intramuscularly, and we've also heard about misuse at times of some topical antimicrobials. So they're just examples. And I'd like to point out here today, we'll be talking about appropriate disposal of antimicrobials. So against all of that background, the purpose of being here today is that nurses are absolutely important to the success of antimicrobial stewardship, and for reasons that include that, not least of which we are the biggest percentage, or nurses are the biggest percentage of the nursing workforce globally. And in some countries, the percentage of nurses is even greater when compared to other health professionals. So that's the first one. But other reasons that we hear talked about in the literature, and I've included a couple of references here, that nurses are a constant presence and have knowledge, skills, attributes that are absolutely important to the success of AMS. Infection prevention and control, medication safety, others listed there. And often at the NCAS, when we're talking about nurses' contribution to stewardship, we like to talk about, just remembering that stewardship and nurses is not just about the medication and the antimicrobial. It's about everything that we've got listed there. Infection prevention and control is part of stewardship because we're preventing the infection from occurring in the first place and potentially the need for antimicrobials. We're educating people about infection and potentially helping them to understand they might not always need antimicrobials. And in the book which is called Antimicrobial Stewardship in Australian Healthcare, there is a chapter that is dedicated to nurses and antimicrobial stewardship. It's chapter 12, and that lists some of the ways that nurses can contribute to stewardship. But this is not an exhaustive list. But you may like to look at that if you're not familiar with it. And it does relate to nurse involvement across all different settings. And I'd like to also point out the Antimicrobial Stewardship Clinical Care Standard, which lists 8 actions which can help to ensure the appropriate use of antimicrobials in management of infections. We'll be talking a bit more about this as we go through this afternoon. But linked to every one of these 8 statements, there's a role for nursing involvement. And I am sorry, what I wanted to point out in this next slide, but clearly I didn't put it in, is that there is also a recently released antimicrobial stewardship a clinical care standard for sepsis that is also available on the Australian Commission on Safety and Quality in Healthcare website. Many of you may be familiar with that, and as the afternoon goes through, various people will be referring to that, that standard as well. So today's program, I haven't got it up here for you. We will be talking about various aspects of stewardship, as you might imagine, and we'll be building our discussion around a case study that I'll introduce in just a moment. But before I do that, I'm just going to stop my sharing for a moment so I can see. What I would like to do is ask for a quick show of hands or reactions, if I could. You've got a reaction screen at the bottom of your screen. I'd like to see some reactions from people and to get an idea for our presenters here of where you've come from today. And I can see, and I think Arjun may be able to see too, we've got a couple of participants who have their hand raised, and we'll come to you in just a moment if we need to. But first of all, if I could just have in your reactions button, if you could let us know, sorry, just having, that's what I wanted to see. Okay. Sorry, I've just fixed my screen. If you could let us know in your reactions button, please, first of all, the clinical setting that you've come from. So for those in our audience, can you tell us how many of you have come from an aged care environment? Okay, fantastic. Thank you. Great to see those hands raised. Quite a few. Still, and the hands are still coming. The thumbs up are still coming on my screen. All right, well, welcome and thank you very much. Do we have anybody here working in a primary care setting? Yes? Couple, fantastic. And welcome. And of you working in primary care, any from general practice? Okay, so I'm thinking maybe more community-based care. All right, and then hands up people working in an acute care hospital, a metropolitan acute care hospital. Okay, thank you. And how many of you working in what you would refer to as a remote hospital location? All right, still quite a few. And lastly, a regional hospital. Okay. All right, thank you very much. That's very, very helpful to us, to all of our us as presenters today, to have an idea of where everybody has come from. And I guess I'm not sure how many of you could see the audience reactions there, but what it shows to us is that we have a range of people here from a broad range of backgrounds and settings today, a really good cross-section of nurses from acute care, primary care and aged care, but also from different settings, from far away and close by to cities. So as part of our program, we're going to work to incorporate you, but please do remember, if you've got questions, to put them in the chat or in the questions and answers blocks. Arjun, before we go on, a couple of people I think may have had their hands raised. Are we okay with that? I can't quite see at my end.
Yes, I can see a few hands raised. There's just one. I'm not sure if it's in response to your questions or if there's a specific question. If there's a specific question, please put it in the Q&A box, and I will make sure that Fiona and the other speakers can see it and respond to it. And then during the discussion, maybe Fiona would like to have a few contributions from the participants as well. Okay. So for now, Fiona, if you want to continue with the first speaker.
I will. Fantastic. But first, before I continue with the first speaker, I would like to introduce our case study for the afternoon, this gentleman's name is Mr. Ross. And Mr. Ross is a 96-year-old male, and Mr. Ross presented unwell to hospital with new onset confusion, lethargy, and a 3-day history of foul-smelling urine. Mr. Ross has a number of comorbidities. He was accompanied to the hospital on this day by his daughter, and he had in place an acute resuscitation plan that indicated that he's not for cardiopulmonary resuscitation or for defibrillation, inotropes or vasopressors. However, it also indicated that he would have intravenous antibiotic supported care and also an indwelling catheter placed. Now, on clinical assessment, Mr. Ross was found to be hypotensive, bradycardic, febrile, hypoxic, and diaphoretic. And what happened was that he had bloods taken for a full blood count, urea electrolytes, LFTs, and liver functions and CRP. He had a set of blood cultures taken, and he also had some point of care bloods taken as listed there. And his initial diagnosis was urosepsis, and as you can see there, he had a cannula inserted. He was started on some antibiotics, and he had some gentle fluid resuscitation of saline listed as it's listed there. So I'm stopping my screen now, and I would like to introduce now Alison Lemoh, who is going to take us through our first session talking about nursing assessment of the person with symptoms of infection. And Alison is an intensive care unit nurse who's working at the Peter MacCallum Hospital, and I'll hand over to Alison so she can let you know a little bit more about herself and take us through this assessment.
Thank you, Fiona. I'll just share my screen. Everybody see that okay? Yep. Okay. So I'm just going to be talking about the initial assessment of a patient with a possible sepsis. So Mr. Ross, my presentation is Could It Be Sepsis? A nursing assessment, recognise, resuscitate and refer. And just to mention too, as Fiona said, I'm an ICU outreach nurse, and I also just did my ALS to instructor candidature as well. So there'll be a little bit of that in there for assessment. Now, let me see if I can go forward. Okay, so we've just heard the case study here. So basically our issues are, we've got a 96-year-old gentleman, Mr. Ross, new confusion, new lethargy, foul-smelling urine, hypotensive, bradycardic, hypoxic, febrile, and diaphoretic. So he presents to your emergency department. Just put there, first of all, recognise, could it be sepsis? Sepsis can have quite diverse manifestations in a patient, which is what can make it sometimes difficult to know whether or not it is sepsis, and thus the question, could it be sepsis? So we've got, fast breathing, fast heart rate, skin rash, diaphoretic, just feeling really, really crap, being very hot or very cold, both hyper and hypothermia can indicate sepsis. Changes in mentation is a really good marker as well of end organ challenge issues, not passing much or any urine, and also weakness or aching muscles and tachycardia. So what is sepsis? Sepsis can be defined as a life-threatening organ dysfunction, and it's caused by a dysregulated host response to infection. So what differentiates sepsis from uncomplicated infection is really this organ dysfunction component. And septic shock is a subset of sepsis, and that's where you're really getting profound circulatory, cellular, and metabolic abnormalities, and this really increases people's mortality risk. And despite adequate volume resuscitation, you can get this refractory hypotension with elevated lactate, and people need vasopressors to keep their blood pressure equal or above 65, and mean arterial pressure of 65. This sepsis is a clinical diagnosis, and so there's no single diagnostic test to really indicate it is definitely sepsis. We now only use the diagnostic terms sepsis and septic shock, and it's important for coding as well. So even things like urosepsis we no longer use, we'll just say sepsis, and then beneath that you could clarify and say urinary source. They're quite new changes. As Fiona mentioned, the National Sepsis Clinical Care Standard released in June this year, and it really just stipulates that sepsis is a medical emergency and how early recognition and response is critical to reduce patient morbidity and mortality. And they really recommend hospitals have sepsis improvement programs and clinical pathways to improve outcomes. And this is inside and outside hospital, I should say, also primary care settings as well. And Safer Care Victoria's Think Sepsis Act Fast is a good example of an initiative that really reduced inpatient sepsis-related mortality by 50%. So the care standard just really promotes evidence-based care delivery and promotes shared decision-making between patients, carers and clinicians, and also talks about sepsis survivorship as well. So patient sepsis risk stratification for our gentleman, Mr. Ross, there are known to be high rates of hospitalisation for sepsis in Australia amongst Aboriginal Torres Strait Islander people, very young children, so they're under 1 year, and people over 85 like Mr. Ross, also those living in very remote areas and in areas of socioeconomic disadvantage. So some of those interestingly correlate with what COVID showed us as well. So if you get this patient like Mr. Ross, you're asking, does this patient have a known or suspected infection? This is really where we start our screening process with sepsis. So we know he has a history of fevers, also other things like neutropenia, chemotherapy, indwelling medical devices, recent surgery, skin, cellulitis, wound, rashes, respiratory, cough, shortness of breath. I've put that he's got respiratory because of his hypoxia, but you'd have to investigate that further. Abdominal issues, pain, peritonism, and then CNS, decreased mental alertness, which Mr. Ross has, or headache, and genitourinary symptoms as well, dysuria and frequency listed there. And then you ask, does this patient have abnormal vital signs? So all of these are part of what we have, for example, at Peter Mac as part of our sepsis care pathway. So signs of severe sepsis, they have 2 or more of the following. So systolic blood pressure under 100, altered mental status, and a lactate greater than 2. So Mr. Ross does meet 2 of those criteria. So we would class him as having severe sepsis. And then on the other arm, you see the early warning signs of sepsis. So high or low temperature, elevated heart rate, elevated respiratory rate, and a high or low white cell count. I won't go into all the details with this, but I thought it's really important to just highlight the organ dysfunction component in sepsis, which is why it's so critical to act fast. It really causes diffuse vasodilation. You get this leakiness in the capillaries. You get redistribution of intravascular fluid, which causes a distributive type shock in severe cases. You can actually get myocardial depression, and microcirculatory dysfunction, hormonal dysfunction. You're getting dysregulation with your endothelial linings, coagulation abnormalities, increased tissue edema. There's an increased risk of pulmonary edema, interstitial edema. The gut can become very leaky, which can allow translocation of bacteria and endotoxins to get into your bloodstream by your portal system. The kidneys, there's a really high risk of acute kidney injury. This is partially due to hypotension, but it's also due to actually intrarenal shunting as well, vasoconstriction, microvascular dysfunction. And then the CNS, you get this encephalopathy, which is both metabolic and cellular dysfunction. And there's more permeability as well in the brain tissue. So it's really very diffuse. And this is just a really nice picture of what happens I got from an article. Again, it just shows that impaired oxygen delivery. It's an energy crisis. You can't clear your toxins. So we want to stop that happening. So resuscitate is our next stop. So stop the sepsis snowball. And I like this. Something small, get bigger. We don't want that to happen. So early sepsis management, essentially 6 key actions in 1 hour. Oxygen, just if it's needed, aiming for SATs of 92 to 96% in most population, and if there's COPD history, 88 to 92. We don't want SATs above 96 with oxygen. We don't supplement for getting SATs above 96. Blood cultures, you want 2 sets, which is 4 bottles, because each set is an aerobic and anaerobic bottle. A venous blood lactate, which helps us to guide resuscitation. It's a non-specific marker of illness, so illness severity. And then judicious fluid resuscitation, IV antibiotics, and within 1 hour if there's organ dysfunction risk, and especially if there is shock. And then monitoring observations and fluid balance. So I'm used to clicking my computer. I have to click on the screen to change. Here we go. I've just got an ABCDE approach for sepsis because I like using ABCD. I think it's nice and easy. And I'll just put in too, before that, your danger, always check your PPE requirements for your own safety. So airway, assess and maintain patent airway. Breathing, there's a rates approach, which is you check respiratory rate, auscultate for added breath sounds, you're checking tracheal position, you're checking effort, people breathing really hard, are they working hard? And saturation, so apply oxygen if it's needed. And then circulation, checking your capillary refill, central and peripheral, and blood pressure. We know Mr. Ross is hypotensive. And then because he's hypotensive especially, you really want to get early IV access, and ideally with a larger rather than a smaller cannula. I'm thinking like an 18 gauge ideally. And then you take blood cultures. And just don't forget, if you're having trouble getting IV access, there is the intraosseous access route. And you can also take blood cultures that way as well, because people can be quite shut down if they're very unwell. And then just going into disability, AVPU is a straightforward one. You can also use GCS. So alert, voice, pain, unconscious. We know he's got altered mentation. Pupils, check your blood glucose level. Yes, there's maybe sepsis, but there may be other causes of altered mentation. Toxins, this gentleman's probably on a few medications with his multimorbidities. Again, checking, are there any other things that might be clouding or adding into his clinical picture? And then exposure, especially with sepsis. Yes, maintain dignity, but you need to see the whole patient. They're all of their body, checking for rashes, wounds, foreign bodies, devices, lines, strange bumps, and such things. Then just going on, latest research with oxygen supplementation. This is from some pretty heavy duty, intensive care journals and such. Really, they say do not supplement. We don't want to go for SATs over 96%. They actually say even between 90 to 94 is safe. But I've put in as per the pathway 92 to 96, which is very reasonable. And in acutely ill patients, liberal oxygen therapy actually can increase mortality. So if you're aiming for SATs above 96%, you actually may be increasing their risk of mortality. It may be small, but it is a risk. So just being pragmatic about it. We're still learning about oxygen. Blood cultures, ideal volume is really about 40 mils. So 8 to 10 mils per bottle in adult patients. And adequate volume sampling is the most important parameter for the detection of bloodstream microorganisms, because they can have quite a low density of bacterial or fungal microbes in the blood. And if they have a central venous access device, then do paired blood cultures, one from the CVAD and one from a peripheral source. And if you get less than 10 mils, which occasionally will happen, the recommendation is to put it all in the aerobic bottle, because there's a higher likelihood that you'll grow, that organism will be aerobic, and also that bottle can grow pathogenic yeasts as well. And up to 30% of patients actually have culture negative sepsis. So don't be disappointed if they don't grow anything. It doesn't mean there isn't anything there. This is quite a busy slide, and I'm not going to go into all the details because the slides will be up later online. But just being on a MET team, you know, trying to get blood cultures from 2 different peripheral sites, if there's no central line for one of them, it can be really difficult. And there's actually some really good evidence coming out to suggest that single site sampling is actually fine. And it's really the volume of blood you pull off that actually matters. So follow your individual institutional guidelines, of course. This is just flagging that research-wise, there may be some new things that will come in time, but they still have to do big trials to prove that it's safe. But yeah, there's really, single site sampling was non-inferior to multi-site sampling to get pathogenic microorganisms. And some places actually support single site sampling as a routine method. A little comment to urine screening in the elderly. Noleen Bennett could probably comment better on this than me, but really asymptomatic bacteria is actually quite common in the elderly, and cystitis is uncommon, but it does increase with age, often related to abnormalities of the urinary tract, probably enlarged prostate and such. Dipsticks alone are not a reliable indicator of UTI, so send the culture. We need to send urine cultures off. And with this gentleman, it actually proves to be really important that they sent the urine culture. And foul-smelling cloudy urine in absence of other features of UTI, you don't need to investigate further. But this man does have systemic features of sepsis, so we do have to investigate, and it is a likely UTI. There's also a high risk of multi-drug resistant bacteria with increased antimicrobial use, and also in aged care residents as well. So just going on with sepsis management, send off other relevant body fluids, swabs for septic screen, ideally pre-antibiotics. So with this gentleman, we really would like to get a urine sample sent off. Also consider imaging. You know, if he's got a new oxygen requirement, you're thinking about a chest X-ray. You know, cancer patients often with questioning PE as well as a differential. And then fluids. Latest evidence, there's lots and lots and lots of discussion about IV fluids in sepsis, really suggests isotonic is fine, and isotonic crystalloid, probably a balanced one, maybe slightly better, plasma-light Hartmann's. Sometimes normal saline, there's talk about hyperchloremia and metabolic acidosis related to it that can affect renal function, but really saline as a first-line fluid in an emergency is fine. And albumin can also be considered if you want to sort of expand the intravascular space and not use as much volume. But I think the mortality benefit's pretty similar to crystalloid. And passive leg raise is a really safe and quick way to assess fluid responsiveness. So you literally can put the person's legs up 45 degrees and you'll get an autologous 250 to 300 ml bolus to the heart, which increases preload, and you just get an idea whether or not that improves their blood pressure. Obviously, caveats being, you know, don't do it if they've got a raised intracranial pressure. If they're vomiting, there's an airway risk, aspiration, you know, use your clinical judgment. But it's a really nice way to check for fluid responsiveness and actually pretty safe. Nothing replaces clinical judgment. There is no one-size-fits-all for fluid resuscitation, and treatment requires close and frequent hemodynamic monitoring and evaluation for response, for any frog and toad fans out there. Ongoing monitoring and management, continue to assess response to resuscitation, assess heart rate, blood pressure, peripheral perfusion, urine output and mental state, and lactate is an independent predictor of mortality in sepsis. It sort of can show mitochondrial dysfunction via reflect mitochondrial dysfunction. And with refractory hypotension, if you've given adequate fluids, that being 20 to 30 mils per kilo of crystalloid, you're looking at early vasopressor support. Mr. Ross doesn't want to have vasopressors, so we honour that. But if that's not the case, you can start noradrenaline, and which basically causes systemic arterial vasoconstriction, and that increases the diastolic blood pressure. It also maintains coronary perfusion, venoconstriction, and increases preload. And it can be given via peripheral IV cannula short term. You just have to be really careful about extravasation because it can cause tissue necrosis. Yeah. This is just about antimicrobial timing, which again, I'm not going to go into too much detail, but really, if the person is very, very unwell, there are signs of shock, you're basically giving antimicrobials within the hour. They can be stopped later if it's not sepsis. If they have signs of organ dysfunction, but without shock, and you really, infection's very low on the list, you can go up to 3 hours to go through your differentials. But if infection is still on the list, you should give the antimicrobials within the 3 hours. And just to remember, it's not going to hurt a couple of doses if it's not sepsis. You can always stop it later. But if we don't give it when they need it, it can have dire consequences. And just the last slide is really just early referral to critical care services is paramount. If the patient continues to be unstable, they're requiring organ supports, it's really important to get expert help quickly. And challenges of getting expert help will vary depending on where you're based. And I don't work in a remote or rural setting, but I can imagine it could be pretty hard at times to get, you know, the experts in quickly. So really thinking ahead, if someone's not thriving, then you want to get help soon. Delays of getting results of blood tests and imaging, and patients may also present later due to travelling time. So, and also follow-up post-discharge as well. So that was sort of my main things. There's a lot of literature now on survivorship. So people needing to get followed up after they get discharged from hospital, as sepsis can actually have quite a lot of sequelae. A lot of people can end up with quite long-term disability. So it's really important, first of all, that we act fast when people present with possible sepsis and treat early, recognise, resuscitate and refer. And really interested in other perspectives and insights this afternoon. And also I just had a couple of questions too, which I'll get Arjun now to put out if that's possible, Arjun. Thank you. So there are just a couple of questions coming up. The first one is, in your workplace, do you routinely use a sepsis screening and management tool or pathway for acutely unwell patients who present with possible sepsis? Okay, and then Arjun, what do I do now to?
So Alison, we have about 50% of participants who've responded. Do you want to wait a bit longer?
Yeah, absolutely. Thank you.
Okay. And once you're happy, I can end the poll and launch the results.
Right. Okay. Thank you. So part of my research is actually looking at the use of sepsis pathways and guidelines in different settings. So it's really interesting to find out what the practice is in different places. Yeah, to see what people use and what they do and how they're guided, because there's a lot that that nurses can do in that first line response to patients. So part of my research is really looking at the scope of practice of nurses and how can we optimise our role in recognising and responding to sepsis and possible sepsis. Okay,
Alison, I think we've got 60% participation. If you're happy, I can stop the poll now.
Yeah, that'd be great.
Okay. Okay, you should be able to see the results.
Yeah, great. Okay, so we have 59% of people say yes, they do have a sepsis screening and management tool or pathway, and 41% say no. Okay, interesting. Really interesting. Okay. And then my second question was just around the sepsis clinical guideline, our national clinical guideline. Were you aware of the new National Sepsis Clinical Care Standard before today's session? Again, just a yes and no answer. the clinical care standard is really a big step for Australia, because it's really working to standardise sepsis care. I think because there's been so much debate around a lot of the components of sepsis care, and also even what constitutes sepsis. So the definition of sepsis has been quite hotly debated as well amongst expert groups. So it's kind of in some ways probably delayed the standardisation, with fair reason, because it is a complex beast. But this is a big step forward to actually have some kind of clinical care standard that we can work off. And most guidelines do reiterate the importance of clinical judgment. The guidelines do not replace clinical judgment. Okay, so 69% yes and 31% no. Fabulous. Right, thank you so much, everyone, for participating in that. Thank you.
Okay. Thanks very much, Alison, for that presentation. And I guess that's quite good for those of you who weren't familiar with the sepsis clinical care standard. We're really happy to think that people have been able to be made aware of a new resource. We have a couple of questions and answers, questions in the Q&A box, but not specific to Alison's session. We can probably take...
Fiona, we have 2 questions about sepsis. If you look at the
yes, I can see it. Yeah, okay.
So you should see there should be a question about a national emergency and urgent care sepsis pathway.
Yeah.
And a second question about ideal blood volume for neonates for blood cultures.
Okay, so Alison, I don't know if you want to answer that, or I can probably speak to that one about a national emergency and urgent care sepsis pathway developed. I'm not sure that either of us can answer that question at the moment, not that we're aware of. The national document at the moment is the sepsis clinical care standard for people to implement in their own workplaces.
That's right.
Yeah.
That's where we're up to at the moment. As far as neonates, I'm actually not going to comment, because I don't work in paediatrics, and I think some of it's weight-based and such. Nick may be able to comment. He's an infectious diseases specialist, but again, he might be adult only. So I'll leave that one hanging, and we might get back to it by the end of the day.
Yeah. Okay. All right. So thanks very much, Alison. And I think your point about how critical it is, as nurses are often the first point of contact, even in primary care. If you can, people can be unwell at home for a long time, and hospital in the home, you may arrive and think to yourself, oh, someone is septic. So thinking through some of those principles is really a good opportunity for people to have this time to do that. So thank you. And aged care also. We're going to move on now. We're moving through our assessment of Mr. Ross and what might happen next. And I've just seen a comment from Nick, who's put an answer, I think, in the chat box, and we can come back to that shortly. But Nick is actually going to present in a moment for us. Our next session is around microbiology, and we're looking at collection of specimens and looking at the journey that the specimens that we collect take once they leave the nurses and the patient at the bedside or in the clinic or wherever, and make their way off to the lab. So Nick Laundy is a fellow at the National Centre for Infections in Cancer, and he's also a consultant infectious diseases physician and clinical microbiologist. And I will hand over to Nick now to take us through the micro aspects of AMS.
Thanks, Fiona, and thanks, Alison, for that talk. Hi, everyone. I'll share my slides in a sec. As Fiona said, I'm from the UK, as you can probably tell. I'm a consultant infectious diseases physician and microbiologist there, but I'm actually doing a clinical and clinical trials fellowship here at PTMAC with the National Centre for Infections in Cancer. So let me get the slides up first. I'm not particularly tech savvy. Okay, can everyone see those slides okay? Super, thanks. Right, So I'm aware a lot of you work in the community, and I think hopefully this will be quite useful for you. And really, I'm focusing on specimen collection and the importance of that really when it comes to how we process specimens in the lab, and the validity of the results that we generate and send out to you. And we do rely very heavily actually on the people taking the samples and the quality of the samples to issue important results for the clinicians. And I'm aware that a lot of you won't be familiar really with what happens when these samples get sent off to the lab, what we do with them. Many of you will have seen and heard the terms gram positives and gram negatives on specimen reports, and perhaps don't know what those mean. So I apologize if you do, and if I'm teaching you to suck eggs and things you already know, but I will I'll briefly touch on those, and also a little bit about susceptibility testing, so how we work out if bacteria are sensitive or resistant to different antimicrobials. And this does all have a bearing on stewardship, and I'll talk a little bit more about that as I go through. I'm very happy to take questions as I go through, or at the end, whatever you like. So just as I said, really, talk a little bit about the basics of microbiology. So broadly speaking, talking about bacteria specifically, we break them down into gram positives and gram negatives. And there are a few caveats to that. So some organisms you can't do gram stains on. So things like syphilis, for example, is an example. And things like Lyme's disease, for example. These just are organisms where they're too small really to be seen on a gram stain, and the gram stain just doesn't work. And I'll go through the laboratory workflow, and this really has three phases. It's called the pre-analytical, which as you can imagine, is largely everything before it comes to the laboratory. The analytical process, what we do in the labs, and then the post-analytical, which is really the job of the microbiologist interpreting what these results mean and issuing reports for the clinicians who are looking at the samples. And then we'll briefly touch on the common pathogens by sites, really. So I think Alison mentioned this briefly, and you'll all be well aware of it, that microorganisms are a part of our body, and we couldn't function really without them. They have various roles, but I think one of the most important roles is that most of these are non-pathogenic, at least in areas like the gut, and they compete for nutrients with pathogens that we are exposed to, and that forms a part of defense really, because all bacteria and living organisms need nutrients. And we have bacteria all through our gut, so E. coli, Klebsiella, things you'll have been familiar with. We have them right from our mouth all the way down to the anus. We have bacteria on the surfaces of our skin as well. But it's when these bugs get into sterile sites that they cause problems, and they can become pathogenic. And you may say viruses. We don't always have viruses. Well, we do. We certainly have latent viruses. So many of us will have been exposed to chickenpox, and this remains dormant and can reactivate as shingles, and other herpes viruses can remain dormant as well. And there are some bacteria when we see them that we know shouldn't be there, and they are always associated with infection. That's true of viruses as well, and parasites. So I've just sort of mentioned a couple of examples which will be familiar with all of you. So tuberculosis, Salmonella typhi, which is one of the causes of typhoid fever, and flu as well. And we mentioned E. coli. This is probably one that you guys have seen on numerous reports that you sent in, probably in urine mostly. Actually, that's through our gut, but when we start seeing it in blood cultures, that's not normal, and that's when you get worried. So the blood cultures should be sterile. Bacteria have different growth requirements. So some, like oxygen, some don't. Many have a preference, but can grow in both. And as I said, gram stain is really how we differentiate bacteria in the initial stages, and I'll talk a bit more about that. And when we get a swab or we get a positive blood culture, the first thing we'll do is put it on a slide, and we'll put it on a hot plate and fix it. And after we've done the gram stain, we'll look down a microscope, and bacteria have characteristic shapes. So some will be rod-shaped, so bacilli, and others will be circular or cocci, and some are a mixture of the two. And actually, we get an idea, or I should say but probably more the biomedical scientists and who are much more experienced with this day to day, can really have an eye for, specific bacterial patterns or morphology just through looking down the microscope at it, and particularly gram-negative bacteria, that some of them can have very characteristic appearances, and they'll say, well, that's likely to be a Campylobacter or something. So what does a gram stain involve? Well, it involves 4 different stains from memory. And firstly, what you do is, after you've fixed the sample on the slide, you flood it with an agent called crystal violet, which is this deep purple stain, and you'd never get it out of your clothes. And what happens is that's taken up by the bacteria, and gram-positive bacteria have a really thick, what's called peptidoglycan cell wall. So that stain stays there, you can't get rid of it, so they will remain purple. But we use what we call decolorizing stains after that, things like iodine, for example, and they flush all of that out so you can start again. And then you give the red stain, something like carbofusion, and that's taken up by the gram-negative bacteria. And this whole process takes a few minutes, and you just do it over a sink, washing off the stain after you put it on for a minute or so. And this is sort of what the bacteria look like down a microscope. In reality, you don't see very many spiral ones and things. There are a group of bacteria called spirochetes, which, as I mentioned, things like treponema, so syphilis, Borrelia, which causes Lyme's disease, leptospirosis. These all have a spiral appearance, but you can't really see them down a microscope. Okay, so gram positives, and this is just to make you all familiar really with certain bacteria that you'll have come across numerous times, I'm sure, both on swab results, urine results, blood culture results, and whether they fall into the gram positive or gram negative category. So gram positive, big group of organisms, and the vast majority that we see are cocci, these circular shape. So staphylococci tend to look like grapes down a microscope. They're all in a big bunch. Streptococci are cocci in long chains or sometimes small chains. And enterococci are normally small chains as well. And we would feel pretty uncomfortable, I think, saying which one of those it is, specifically streptococci or enterococci, just from a gram stain. We have to do further tests. But these are some of the bugs below that you'll be familiar with that it can turn out to be. Gram-positive bacilli, in actual fact, a lot of those are contaminants, but there are a few important ones. So things like Clostridium, you'll know of Clostridium difficile, and Listeria being another important one. And gram-negatives, so again, if you look at the column on the left, that group E. coli or Escherichia, Klebsiella, Enterobacter, Proteus, these all are grouped together called Enterobacteriaceae, so gut coliforms basically. And they form part of our normal gut, Salmonella, not, but the others. And these are red and rod-shaped, and Vibrio, so you might not think you've heard of that, but you all will have done. So Vibrio cholera and Campylobacter, of course, these are rod-shaped ones, and these are obviously pathogenic. Pseudomonas is part of the normal microbiome, but can cause infections. And then there's some gram-negative rods or Coccobacilli, and some examples of those are things like Haemophilus. So you'll have heard of Haemophilus influenza. Gram-negative cocci are pretty rare, actually. We don't see a lot, but the big one that's really important is things like Neisseria species. So Neisseria meningitidis, the one that causes the worrying bacterial meningitis that you'll all be familiar with, and gonorrhea, Neisseria gonorrhea as well. So it's probably a good time just to see if anyone has any questions at the moment. Otherwise, I'll just plod on. Can't see any. Okay, so laboratory workflow. Well, as I mentioned at the beginning, 3 stages: the pre-analytical, before the samples get processed in the lab, right up to the booking process, the analytical phase where we're processing them, deciding what tests to do on them, and then the post-analytical afterwards, where we're interpreting the results and issuing the report. So pre-analytical is probably the one section that is most relevant to you guys, and the one that hopefully you can get something out of this presentation from. And it's a really important stage. So it takes in the process right from when you're doing the consultation and the examination of the patient, deciding whether you think there is a problem even, and you need to take a sample, be it sputum, a swab, urine, filling out the form. And obviously, you know, everyone's really busy, and I think it's very straightforward now with a lot of these automated requests to not put in a lot of requesting information, and I've seen ones where it's just been a full stop sometimes, or some people put routine, and unfortunately that can be quite a hindrance in the lab, because we don't know what any of the symptoms the patient has, or if they even have symptoms. And when you go back to the fact that bacteria are a normal part of our body, and as Alison mentioned, you can get asymptomatic bacteria, we're often left in this predicament thinking, you know, is this a true infection, or is this just colonization really? And I would encourage, where you have time and opportunity, to even just put a sentence just saying things like, you know, dysuria or fever, or you know, has a red swollen leg with fever, something like that, because it really just is that added bit of information to ensure we can issue an appropriate result. How the specimens are collected, again, for those of you working in aged care, I'm sure I would know how difficult it is with, you know, getting things like urine samples. Many of these patients are incontinent. Sometimes, you know, it just isn't possible to get things like, you know, a clean catch, and we do appreciate that. But you know, where you can, trying to get samples that aren't contaminated, obviously, will lead to the best results. Transport to the laboratory, generally that means samples, you know, being taken to the lab quickly. Most of you who aren't working in hospitals won't need to worry about things like CSF, where you know, that's quite time critical. But urines is also important as well. So those that urine samples are allowed to stand around for a long time, we know that, you know, bacteria can proliferate actually, and you get an inaccurate result in terms of, you know, what quantity of bacteria are actually around, and it can also affect the microscopy as well. So there are preservatives like boric acid, which can be used where you think the urine is going to take some time getting to the lab. And again, you know, just ensuring that, you know, it's accurately processed. Is this a catheter urine sample? Is this a clean catch urine? Is this a pad urine? It's all relevant. And going back a little bit to what Alison said about blood cultures. So probably one of the difficulties I have the most with sort of interpreting blood culture results is those patients who have lines in, because you can of course get primary line infections, but you can get contaminants as well, which is very easily done when the samples are taken. So clear labeling of the blood cultures. This is the red port from the PICC line. This is a peripheral blood culture, and ideally doing them at the same time is really helpful as well. And this is really just summarizing what I've just said. So the analytical process, well, I'll try not to go into too much detail, because I suspect that it's probably not necessary and a bit boring for some people. But essentially it's where we, you know, get the sample and we take it down a stream that's relevant for that sample. And in the lab, we have things called SOPs, or standard operating procedures. And this allows for reproducibility and ensures the process is valid, and removing sort of errors. And it's a stream of different things that should be done depending on the sample you receive, and some clinical parameters as well. So for example, we have one for processing urine, for processing blood cultures, for CSF. If it's a CSF, for example, it's from a neonate, we might do different plates than we would do from an adult. So again, the clinical information is useful. And based on the SOPs, we might determine different culture mediums that we use, depending on what we see down the microscope. When the scientist says, oh, this looks like a particular bacteria, we might choose to change the incubation requirements or the temperature requirements to increase the chance of growing that bacteria successfully. And then after we've grown a bacteria on a plate, there are a lot more automated tests, to be honest, now, which can give molecular results. So based on genetic fingerprints of bacteria telling us what they are. And there are some other automated technologies as well. But actually, previously, it was a lot more done, by, if you like, almost detective work on the bench. And there's some pictures down on the bottom right of different agar appearances, and probably the sort of agar appearances we see most commonly are the one you can see with Staph aureus there, with these little colonies there, and the others you don't see too often. And the colonial appearance on the agar plate, again, a skilled biomedical scientist can often say, oh, this looks like E. coli, and sometimes the plates, although they shouldn't be, would be smelled in the past because certain bacteria have specific smells. So an example would be things like Haemophilus influenza or Strep milleri. They have quite characteristic smells. And that picture just on the top right is called an API strip. And this is getting increasingly more redundant now. It used to be used back in the day quite a lot before all the automated technology. And essentially what you've got there is lots of different wells with different biochemical substrates that some bacteria will metabolize or use. And you put the bacteria in the different wells. And there's a reference chart looking for color changes. And based on that, you can determine whether this is likely to be an E. coli or a Klebsiella. But as I said, we do that far less now. And then, we tend to come out with the report saying, this is likely Staph aureus or this is likely E. coli. I will come to the sensitivities in a minute. And that comes to the lab. And we then have to decide, is this likely colonization? Is this just a skin swab, clean skin, or a urine sample with someone with no symptoms who's in their 90s, where that result might not actually be relevant? And this comes back to sort of stewardship, really. If we issue all those reports, it's tempting, I think, for people to see a bacteria and say, I need to start antibiotics. But of course, again, with what Fiona mentioned, antibiotics are not always appropriate. And not only on a population scale does it increase the chance of selecting out resistant organisms, but for this often frail and comorbid patients, it increases the risk of other problems. So C. diff is a classic one. And, or just toxicities like diarrhea and things. So that's where the clinical information really is useful for us in determining whether we should release that report and release antibiotic sensitivities for it. So this is just a quick question for everyone. And I'd be interested just for all of you just to fill in the poll to decide which phase of the workflow process that we've outlined do most errors normally occur. Is it the pre-analytical, analytical, or post-analytical? And I'll just give you a minute to do that. Okay, that's probably enough. Should we see what the results are? Good. Okay, yeah, absolutely. So actually, pre-analytical is by far and away the stage where most errors occur, and not too far away, actually, that number who've picked it from the proportion where the errors occur. So it's about 60 to 70% actually of errors occur in the pre-analytical phase. And you can imagine why that's more likely to occur. And this isn't to apportion blame to anyone. I think it's the less regulated part. And so it means that errors are more likely to occur. Things are done more on an individual basis and more subjectively. So errors might be things like, things not being labeled appropriately, samples being sent where they've been labeled as something else. So often we'll get sputum, and we'll get a swab sent, for example. And this can lead to quite a lot of errors. The analytical is quite formulaic now and structured with algorithms, and that's true of post-analytical as well. So I suppose the take-home messages from the pre-analytical phase for all you guys is just have a think before you send a sample. So classically, urines and swabs of legs and things like that. Do I need to do the sample? Why am I doing it? Am I worried about an infection? Because invariably, if you send a sample, we're going to grow something. And then we're left with another question. And taking the best sample you can, as I said, it's often very difficult, and we appreciate that. But if you've got a area of skin breakdown or erythema, is there any pus that you can swab? If someone's done a deep aspirate, that's often more useful. Trying where you can to get a clean catch urine rather than from a pad or a catheter. But obviously it is difficult. Ensuring as much information is put on the request as possible, and labeling, again, going back to what Alison said, there's been a lot of studies that have shown that the amount of blood you put in a blood culture bottle, or the inoculum, increases has a direct determination on the chance for positive yield of growing something, and classically 8 to 10 mils per bottle. But patients, particularly the elderly, can be difficult to bleed, and so making the best use of what you can. So if you only get 8 to 10 mils, putting it all in the aerobic bottle, as Alison said, one set rather than splitting it all across 2 sets is certainly preferable. And paired line cultures, so doing where you can a PICC line or a CVC blood culture with a peripheral, when you guys are able to do that, is really useful, because there can be situations where we just don't know, is it the line infection or a systemic infection? And actually, if one comes up really quickly, so 4 hours from the line and at 20 hours peripherally, then we might sway slightly more towards it being a line infection. But obviously, again, the amount of blood that's taken from each does influence it. And a sterile technique is clearly important to reduce the chance of contamination. So I won't spend too long on susceptibility testing. It's more just for interest, really. You'll all see comments which are authorized outcome reports, S obviously being sensitive, I for intermediate, which often means if we use a higher dose of the antibiotic, that would normally be successful, and resistant. And the middle picture is essentially an agar disc diffusion plate. And what you can see there is obviously an agar plate with medium. That looks like something called a Muller-Hinton agar plate. And you can see all that muck at the bottom. That is bacterial growth on the plate. And those different white discs are impregnated with antibiotics, and they have a specific concentration. And that circular clearing around the discs represents bacterial inhibition that isn't growing. And there's references where a specific diameter equates to whether it's sensitive or resistant, and the lab staff will use calipers and measure it and say, this is a coliform, a gram negative like E. coli, and it should be X diameter, or it's sensitive or it's resistant. The images on the left and the right of your screen are really one of the same thing. They're both called MICs, or minimum inhibitory concentrations. The one on the left with all the little wells is called broth microdilution, and essentially it's lots of different wells with different concentrations of antibiotic, or with a specific amount of the bacterial inoculum. And we look for the lowest concentration of antibiotics where you don't have any turbidity or any growth to determine that minimum inhibitory concentration. And on the right, that's called an E-test. So this is a antibiotic impregnated strip, and with gradually increasing amounts of concentration of antibiotics. And you see this ellipsis clearing of bacterial growth. And right at the bottom, where the bacterial growth starts, that's where we have the cutoff for the minimum inhibitory concentration. And MICs really are the gold standard, as opposed to discs, where you really need to be confident in the antibiotic susceptibility. So we would always do MICs when we're thinking about things like endocarditis or meningitis, because we need to be really sure that the antibiotic and the dosing is appropriate. We wouldn't do it, for example, classically or mandatory for urine samples, we might be happy with discs. Cascade reporting, so essentially we release susceptibility data for the narrow spectrum antibiotic that we can get away with, our bit for stewardship, i.e. if you've got a Proteus growing in a urine sample and you think it's causing an infection, often they might be sensitive to amoxicillin, or if it's trimethoprim sensitive, we'd release that rather than ciprofloxacin, which carries more risks. But sometimes, we will have more resistant bacteria and we just have to release broader antibiotics. So interpreting results, this goes back really to what I said before, that most of the job we try to do, but we're informed by the information we get and as to whether this is significant or not. So things we look at, if we get a sputum, for example, we look at the ratio from squamous cells or epithelial cells, which is generally a marker of contamination relative to polymorphs or white blood cells, to try and see if this is a contaminated sample. Lots of white blood cells, stands to reason that's more likely to be infection. If we're just seeing one type of bacteria on the gram stain and growing that on the culture, that's probably more likely to be significant. Whereas if you get lots of things growing, things that are normally found in that area, then it may well be a contaminant. There are sort of broad criteria for determining if something's significant. As I said, it should be the predominant thing you're seeing in the gram stain in the culture. It should be a bacteria that is known to cause infections in those areas. So, if we get a Staph aureus from a wound ulcer or a group A strep, you think, yeah, we know it causes infections in these areas, or we get a strep pneumo from a sputum. Whereas if we got an E. coli from sputum, particularly someone who isn't ventilated in ICU or hasn't got COPD, but is just someone in the community, would think that's a bit odd. Why have they got an E. coli there? Is it a contaminant? So we look at the other parameters like the epithelial cells. But as I said, there are specific patients who are more vulnerable. They've got underlying structural abnormalities of their lungs, for example, or in ITU, where a little bit all bets are off. The microbiome shifts and changes as antibiotics have been given, and they've had devices put in. So Staph aureus, we will often find on sputum. We know from studies around the world that intermittent colonization of people is very common, somewhere in the order of probably 15 to 20%. And so, again, we have to interpret it in the clinical context. If someone says actually they've had the flu and they've now got pneumonia and we're just getting Staph aureus, we know there's an association there, so that might be relevant. Actually, I can't see all of my slide here that well, but this is just taking you through really a specimen report. And on the gram stain, you can say it's mucopurulence, there's pus in there. So immediately you're thinking, well, that's not very good, probably some infection there. There's a high ratio of pus to epithelial cells, again, going down the line of infection. There's not many epithelial cells, only 1+. And I can tell you that Pseudomonas and Achromobacter are both gram-negative organisms. And so they're heavy growth in the culture, and there's plus gram-negative in the gram stain. So this is all saying they're definitely there, and they're there in significant amounts as well. And so I think in the right patient, it should normally be someone with some like bronchiectasis or intubated in ITU. We would definitely release the sensitivities for these. So question 2, I think when I was preparing this question, I thought you guys may already have seen the full case study, because it's a similar actual report to that. But anyway, it'd be interesting to see what you guys say. So 86-year-old nursing home resident, we get a catheter urine sent. The history just says routine, no other information at all. Microscopy's got 2+ epithelial cells, 1+ white cells, 2+ protein, and you get E. coli, but it's an ESBL. And ESBL, you've probably seen before, but what it stands for is extended spectrum beta lactamase, and that just means a bit more resistance. So you can't use things like beta lactams, so amoxicillin, augmentin, cefalexin, all of these are out really. Sometimes you can use things like Cipro and Bactrim. But anyway, with that information, do you think the lab would routinely release sensitivity sensitivities for the GP. Okay, that's probably enough time. Yay or nay? Okay. Yeah, so I think it probably depends a little bit on lab. And whilst I said, it's more regulated in the analytical and post-analytical phase, of course, some microbiologists will feel more comfortable with releasing antibiotics for patients when you see a more resistant bug. But the fact that it's more resistant shouldn't necessarily move us down the line of releasing antibiotics for it. What we know is this is an elderly patient, and she's from a nursing home. A very high proportion of these patients have asymptomatic bacteria. It's just very common. And about 100% of catheters are colonized with bacteria, about 100. And so they stick to the plastic. So if you send a catheter urine sample, you will grow something. And there's nothing in the history there that tells us there's any concern about infection. There's also a bit of contamination. So there's 2 epithelial cells. A urine dip is pretty useless, to be honest, in a catheter sample. Yes, if you had, 4+ white cells and nitrates, and it was there was reports of fever and things, then that might be relevant. But based on all of that, I wouldn't actually. I would probably say that do contact us if there's concerns, and we will release sensitivities. But otherwise, this is probably just catheter colonization. And the reason that's particularly important, or more so for a resistant bug like ESBL, is, as I said, the options would be things like Cipro, if it's sensitive, or Bactrim, both of which in the elderly carry risk. So C. diff specifically, some acute renal impairment, problems with myelosuppression. So they're not risk-free, even leaving aside antimicrobial resistance. So many wouldn't release that. And again, that's why the information is all important. And this is just going back to what I said, really. So asymptomatic bacteria is very common, particularly in catheters, elderly people. You do see it even in healthy premenopausal women. There is a subgroup of people where we would always treat asymptomatic bacteria, and that would be pregnant women, just because the risk of getting pyelonephritis and sepsis is the stakes are higher, obviously. What we may do if we had mixed growth and 2 epithelial cells and the patient was fine is I might ask for a repeat specimen just to see if we're growing anything. Things that favour a true urinary infection is a high colony count growing, so 10 to the 6 in patients who are symptomatic, lots of white cells, and pure growth, not contaminated, low squamous cells. Now this wasn't my slide, I'm afraid, so I'm just trying to sort of interpret it myself. But I think, from memory, whilst I can't see the top of it, it's a catheter urine sample. But there are quite a few white cells. But there's also a lot of leukocytes as well. But again, there's the caveat about how useful is a urine dip from a catheter. There's also mixed growth as well. So that suggests it might be just a colonized catheter. The difficulty in this case, and I suspect why it was put in, is one of these isolates, the Klebsiella pneumoniae, has something called an MBL. And you're not expected to know that, but that stands for metallo-beta-lactamase. And it's a type of carbapenemase producing enterobacteriaceae, or CPE, the ones we really worry about and are super difficult to treat. So these ones are normally relatively infrequent, particularly in Australia, less so in the UK. And we would probably deal with these on a case-by-case basis. And perhaps more relevant for this patient is the infection control side of things, because what we don't want is this being passed on to another member of perhaps the nursing home where they are. So I would ring this result out, actually, and make sure that that patient is in a side room with appropriate barrier precautions, specifically for things like handling urine and stool and things. And we may get a bit more information before releasing the report. But actually, by virtue of having a resistant organism, doesn't necessarily mean you need antibiotics. It might just be sticking around. They're no more virulent, if you like, than a susceptible bacteria. It's just that if they do get in to cause an infection, there are less treatment options. Wound swabs. So wound swabs are very tricky to interpret. Again, you swab the skin, you're going to get skin flora. So, you know, try and just send swabs if you can, if you're suspicious of infection, again, open sores and ulcers. But bear in mind that, you know, big open wounds like diabetic ulcers, for example, if you swab an ulcer, you will get bacteria, and often we'll see E. coli, Klebsiella coliforms. Very rarely these are causing any of the mischief. They're often colonizing. So, and that's nothing that the sender can do about, really. If you're worried about infection, you have to send it, but we do try and interpret the relevance of that, really. Yep, sometimes you don't need antibiotics. So in the old days, you know, draining an abscess would be sufficient, particularly in healthy patients. But in reality now, people are less comfortable with just draining, you know, an abscess, and we will normally give a few antibiotics because we feel happy about mopping up any residual infection. Yeah, I mean, this is fairly basic for all of you, but, you know, if you see signs of local inflammation or infection, then that's more suggestive of infection than just having, you know, a chronic open wound, really. How are we in time? So I'll be a bit quick. So common pathogens, again, this is really just for interest, really. So there are particular bugs that cause infections at particular sites. So group A strep is the commonest cause of tonsillitis, and can also cause things like necrotizing fasciitis and cellulitis. Strep pneumo or pneumococcus, commonest cause of pneumonia worldwide, probably in the order of 50%, 60%, and also causes sinusitis and otitis media. There's lots of different bugs that can cause pneumonia, but they're much less common. Haemophilus influenza, Moraxella, Legionella. Viruses are very common as well. So I'm sure all of you have, you know, probably irritated by people saying we don't need antibiotics for every chest infection, and that's true. So, you know, particularly in winter, particularly if you've got compatible illness in someone who isn't very vulnerable, where it sounds like a cold, you know, it probably is actually. And I think a bit of judgment there may prevent as much use of antibiotics as is currently seen. Yeah, it's just some pictures of cellulitis and a boil, Staph aureus, and group A strep, or group C and group G strep are the common organisms there. Urine, coliforms, E. coli, Proteus. Sometimes enterococci can cause infections, but they're common contaminants. Staph aureus, if you ever get Staph aureus in a urine, it's not a catheter, please send another one. The reason for that is people who have Staph aureus bloodstream infections can, when there's a high amount, shed it in the urine. So if we get it again, we always do a blood culture on them. And just to summarize, I mean, there's obviously a bit of a whistle-stop tour. I hope that was quite useful for you. I think, you know, the main thing to take away really is that, you know, microbiologists and infectious disease physicians recognize that it is difficult to sometimes get the ideal swab, but it's so helpful for us interpreting the results and from a stewardship perspective to, you know, put as much information as you can, sterile techniques, trying to take good samples with the right amount. And this goes a long way to us releasing susceptibilities where they're not needed and not giving antibiotics unnecessarily. Anyway, hope that was of some help. I see there's a few chats, so I will open up for questions. Nope, no questions, just saying the poll's closed.
Thanks for that, Nick. There's a couple of reactions, a few hand claps coming up there. Sometimes when you're taking in a lot of information, it can be the questions don't immediately spring to mind. So it may well be that some of you have a burning question that you've been thinking about for a while with regard to Nick's topic or in regard to any of the topics that we're covering this afternoon, or anything else in relation to stewardship that perhaps we haven't got listed on the program. So we're about to take a break, but maybe take a piece of paper and write down your burning questions so you don't forget it, and then we can endeavour to discuss that later on this afternoon. And when we come back, we may get you to type your questions into the chat or the Q&A box. But for me, thanks, Nick, that's a great presentation. And really, I think it's just always, you know, when you're thinking about it, the patient-facing end, when you're there, whether it's in the clinic or at the bedside in the hospital or in an aged care home, you know, that the whole ordering process and the whole specimen collection process is actually part of the whole microbiological journey, and so important as part of that, really highlighting that collaborative aspect of AMS, I think. All right, we're going to take, sorry, Nick, did you want to say?
No, I was just saying thank you. Yeah, that's
Okay,
great.
great.
Have to take questions later on.
We will take a break now. According to my clock, it is 3:34. So if we come back at 4:45, please, and we will be starting again. We'll be hearing from Caroline speaking about some of the pharmacological aspects of stewardship. 3:45. And hopefully you've all had an opportunity to have a bit of a walk around and a stretch. And we'll just wait a minute or two to see if anyone's going to log back on. Some people might have logged off during the break. So while we're sitting waiting, just before we begin, as I said before the break, if there are any burning questions or things that you want to ask about stewardship, we've had one or two come in the break, please type them in the Q&A box, and we may not answer them immediately as we go along, but we have got time at the end for a bit of a panel discussion where we'll all be here for questions and answers. So please put those answers in if you would like. Put those questions, you may have the answer too. Put those questions into the box. All right, I will move us right along now. Our next presenter this afternoon is, I'm just making sure, yes, I have got the right order. Our next presenter this afternoon is Caroline Chen. And hello, Caroline. And Caroline is going to be talking to us this afternoon about a bit of pharmacotherapy in relation to antimicrobials and the right drug for the right bug, if you like. So Caroline is a pharmacist with the guidance group at the National Centre for Antimicrobial Stewardship at Peter Doherty Institute. And I will hand over to Caroline.
Lovely. Thank you very much. Sorry, I'm just getting my presentation sorted. All right, is that coming up okay? Excellent. All right, thanks very much for that, Fiona. So before the break, Nick went through all of, or he talked to you a lot about the principles of microbiology and went through some of the bugs. What I'm going to be going through in my session is to talk about the drugs that we use to treat them. So I'll start off with some basic kind of general principles when we're thinking about antibiotic pharmacotherapy, and then I'm going to launch straight on into all of the antibiotics. I will say that I'm really just going to be covering antibiotics in this talk. There are obviously antifungals and antivirals. I'm not going to be talking about those at all because they're a whole separate talk on their own. And there are lots and lots and lots of antibiotics. I can't cover all of them, but if you have a good enough sort of understanding of most of the antibiotics I'm covering in this talk, then that will hold you in very good stead. So the very first thing I wanted to say is that learning about all of this stuff is really not easy. I struggled with it a lot when I was going through pharmacy college, and it really wasn't until I kind of started in the ID space that I kind of forced myself to learn a lot of this and to and to think of a way that I could make sense of it all. And I'll go through what my approach was that I found useful when I was learning about antimicrobials. And the reason for that really is I just found that everything sort of sounded the same. All the bacteria sounded the same. The antibiotics sounded the same. And it's a bit different to learning about cardiac drugs or diabetes drugs, where you sort of learn a principle and it doesn't change. Generally speaking, with antibiotics and bacteria, the bacteria, their resistance pattern changes. And so something that you might have learned a couple of years ago might not be relevant. And all the antibiotics sort of have overlapping spectrum over each other. So the first thing to say is that it's, don't feel bad if this is a bit confusing and difficult to understand, because I think a lot of people struggle with that too. If we think about, broadly speaking, how antibiotics are used, they could sort of be broadly classified into these following areas. So we use antibiotics, we can use them empirically, and this is basically our best guess. We treat an infection without necessarily knowing the causative pathogens, but we have a pretty good idea of what we're aiming for. We know the sort of the spectrum of activity based on the location of the disease of the patient, how severe they are, if they've got other risk factors, and also your local antibiogram. Ideally, what we would be moving towards is something called directed therapy, which is where we have information about the organism. We know what the pathogen is, we know what its susceptibility profile is, and so we can really target antibiotic therapy based on that. Another method of using antibiotics is for prophylaxis, and this is where the patient doesn't have an infection yet, but they're undergoing, they're in a situation where an infection is very likely unless we give antimicrobials. So the classic scenario is surgical prophylaxis. Also for patients who have a splenectomy, we give them long-term prophylactic antibiotics for that. And then the final category is something called synergy. And this is where the antibiotic is prescribed not so much for its direct effect on an organism, but usually it's there to increase the effect of another antibiotic. So something like endocarditis, where we use gentamicin at a very low concentration to try and sort of boost the efficacy of the beta-lactam that it's used concurrently with. I will spend just a little bit of time talking about some pharmacokinetic and pharmacodynamic principles. And so Nick briefly introduced the concept of an MIC, or a minimum inhibitory concentration. But it allows us to sort of understand that antibiotics can have either a time-dependent activity or a concentration-dependent activity. So what I've got here is called a drug time concentration curve. So I've got time on the x-axis and the drug concentration on the y-axis. And so what happens is when you administer an antibiotic, either intravenously or orally, that antibiotic gets taken up and absorbed in your body, and the concentration gradually starts to increase. It reaches a peak, and then eventually your body's sort of elimination pathways kick in and the concentration of the drug starts to come down again. The blue line here is what the minimum inhibitory concentration of, say, a particular bacteria, a particular organism would be. And so in that situation, when the antibiotic has a high enough concentration that it's above the MIC, then it actually starts to have an effect on killing that organism. And generally speaking, when it's below the MIC, it doesn't have an effect. So antibiotics can be thought of as being time-dependent antibiotics. And what it means is that the antibacterial activity is dependent on how long this concentration stays above the MIC. So for these drugs, what you really want to be doing is that once the concentration starts coming down, you want to be giving your next dose so that as the first dose is wearing off, your second dose is gradually coming up. And so you're keeping the concentration of that antibiotic above the MIC. For these sorts of antimicrobials, usually, generally speaking, having a higher concentration doesn't necessarily mean that it's better than at a lower concentration. And so there's a lot of antimicrobials that fall into this category. For example, all the beta-lactams, clarithromycin, linezolid, clindamycin. And that's in contrast to something called concentration-dependent antibiotics, where the higher the concentration, the greater the ability for it to kill the organism. Now, obviously, the higher the concentration, also the increased likelihood of side effects. So, you know, the classic drugs are gentamicin and ciprofloxacin. And so what you can also take advantage of is that even though the concentration starts to dip below the MIC, a lot of these antimicrobials have something called a post-antibiotic effect, where the drug is sort of, the bacteria are kind of shocked for a period of time. We could also think of antibiotics as being bactericidal, where they actually kill the organism, or bacteriostatic, where they prevent the growth of the organism and rely on the body's immune system to take over. Generally speaking, it doesn't really matter which one it is, but there are some situations like CNS infections or endocarditis where the preference may be for a bactericidal regimen. These are some of the things that I would think about when I'm reviewing an antibiotic, and I've got Homer Simpson here. I know he's a bit old school, but nonetheless, he's sort of, it's a good base point to start to think about some of the things that I would consider. So the very first thing that I would look at is, well, how large is the patient? Because most antibiotics do need adjustment in obesity. If it's an oral antibiotic, you need to think about whether food has an impact, and there are a lot of oral antibiotics where it does. So some of them need to have very specific instructions in terms of being given with food or without food. Also, if the patient's on, enteral feeding, or if they've got significant nausea, vomiting, or diarrhea, where they're not able to absorb that oral antibiotic as well as they should. If they've got renal impairment, a lot of antimicrobials require dosage adjustment. If they've got liver impairment, then it might impact on whether we choose to use that antibiotic at all. If we're treating a CNS infection, then we need to think very carefully about whether or not that drug actually penetrates into the CNS. And if it does, we usually require high doses. And also with certain IV antibiotics are formulated such that they have quite a bit of salt. So piperacillin tazobactam, for example, and the intravenous form of amoxicillin clavulanic acid have a reasonable amount of salt. And because you're using them 3 or 4 times a day, you just need to be mindful if the patient has any salt restrictions. So, so another way of classifying antimicrobials is according to their mechanism of action. So antimicrobials can work on various different parts of the bacterial organism. They can break down the cell wall, or they can act on various genetic components within the bacteria themselves. I'm not going to be going through all of these antimicrobials in this talk, but I will try and talk about most of them. So when I was learning, trying to make sense of learning about antimicrobials, I found it really helpful to visualize them in this way. And this is just what helped me, and hopefully it'll be helpful for you. So what I've tried to do, and I'll use this as a basis for explaining the kind of the different coverage and the spectrum of the antimicrobials going through the rest of this talk. I've got all the gram-positive organisms above the line, the gram-negative organisms below the line. I've got sort of the anaerobes off to the left-hand side. And this x-axis arrow is meant to represent increasing resistance. So, for example, here I've got sort of your basic staphylococci, and then I've got methicillin-resistant Staph aureus up this end. Similarly, VRE is kind of a more resistant type of enterococci. With the gram-negatives, so I've got your commonly seen gram-negatives, E. coli, Klebsiella haemophilus, Proteus mirabilis, and the ESBLs are meant to represent those gram-negative bacteria that have developed a higher level of resistance. Pseudomonas tends to be more resistant than these, so I've sort of popped them a little bit further along the right-hand side. And then this group of organisms called the ascapum organisms, which comprises of these. This sort of changes over the years, and the acronym changes a bit over the years, but generally speaking, these are quite highly resistant gram-negative organisms. So it's a little bit, I suppose it's a little bit simplistic, but broadly speaking, it does the job, and it was sort of quite useful for me. So I'm going to start off with the beta-lactams, and I've got a quiz question for you. So this is a multi-select. Which of the following are beta-lactams? Select all that apply. And I'll give you 20 seconds to go through this. All right, Arjun, thanks. We might see what the responses are. Excellent. All right, so I will go through this, but the correct answers are that meropenem is a beta-lactam, ceftazidime is a cephalosporin, which is a beta-lactam, benzyl penicillin is a penicillin, which is a beta-lactam, but ciprofloxacin is not. And that's just a summary of the correct answers there. So what is a beta-lactam? Now, when we talk about beta-lactams, it's a broad, it's sort of a class of a class. The beta-lactam refers to this component in the chemical structure of these four classes of antimicrobials: penicillins, cephalosporins, monobactams, and carbapenems. And so, as you can see, they hold this all in common. Now, when we talk about organisms that produce a beta-lactamase enzyme, what that actually means is that there is an enzyme that cleaves or sort of breaks down this component of the chemical structure. And so the structure sort of breaks apart and isn't able to have its intended impact on the necessary receptors within the bacteria. So basically, it makes it ineffective. And when we talk about, so there's a class of drugs called beta-lactamase inhibitors. And what a beta-lactamase inhibitor does is that it inhibits the beta-lactamase, makes that particular enzyme ineffective. And so the chemical structure is able to stay intact and have its effect. There is cross-reactivity between these classes, and traditionally, I know when I was going through pharmacy college many years ago, it was something like we sort of talked about a 10% cross-reactivity between penicillins and cephalosporins. But the thinking around this has really changed a lot in the last couple of years. And Jason Tribbiano, who ran an allergy session yesterday, has done a lot of research in this area. And really the cross-reactivity is actually much less than what we originally thought. So whilst you obviously need to be mindful in patients who have a penicillin allergy, if they're prescribed cephalosporins, it is, I suppose, not quite as common as what we thought. And so the cross-reactivity of an allergy is thought to mainly be because of the side chains, so the R1 side chain or the R2 side chain, rather than the beta-lactam ring itself. All right, so I'm going to launch on into the penicillins, and this is just, there's a website called giantmicrobes.com where you can buy cuddly little soft toy versions of microbes and of penicillin. So this is just what it looks like, because penicillin comes from the penicillium mold. So penicillins are a really diverse range of antibiotics. Different penicillins have a huge variation in spectrum of activity, and generally speaking, they are very well tolerated. In terms of a class, sort of as a whole, probably some of the things we do think about is certainly it does require dose reduction in renal impairment, but because of its sort of safety profile, you sort of don't want to be too trigger happy in reducing the dose of penicillins, because if you're having, if you're underdosing, then that's arguably worse than slightly overdosing. They can cause immunological reactions. So allergy is probably the main one, as well as interstitial nephritis. But the interstitial nephritis in particular sort of generally happens with sort of prolonged courses, and also prolonged high-dose penicillin can cause seizures or coma or hallucinations. So I'm going to start off by talking about the narrowest spectrum penicillins and then gradually work my way outwards. So the first one will be benzyl penicillin, which has coverage over streptococci and enterococci, and flucloxacillin, which has coverage over staphylococci. Needless to say, these are the kind of the traditional sensitive varieties of those. They certainly don't have any impact on MRSA or VRE. Benzyl penicillin belongs to a class of, I suppose, natural penicillins. Confusingly, some clinicians will also call this penicillin or plain penicillin, and they're not referring to the class penicillins, they're referring to the drug penicillin, which is benzyl penicillin as the IV form, or phenoxymethyl penicillin as the oral form. And so they have really good coverage against strep, which makes them really useful for pneumonia, as well as for Enterococcus faecalis. And so generally speaking, the main clinical uses for these drugs are in pneumonia for the coverage of strep pneumoniae, and also certain types of cellulitis, so this sort of non-purulent cellulitis caused by strep pyogenes. If we think about, so the other type of narrow spectrum penicillin are the anti-staphylococcal penicillins. So benzpen and phenoxymethyl penicillin don't really have any effect on staph. Of the anti-staphylococcal penicillins, Fluclox is probably the main one that you would know of. Methicillin is not really used in clinical practice anymore, but I've put it there because it's what is used in microbiological testing. So when we talk about MRSA, it's methicillin-resistant Staph aureus. And so basically what we mean is flucloxacillin-resistant Staph aureus. And so it's used for Staph aureus, obviously not for MRSA. And also it does have some streptococcus coverage as well, but not against strep pneumoniae. So you would never use it for strep pneumoniae. And usually from a clinical point of view, we use it to treat purulent cellulitis, which is typically what Staph aureus causes, and kind of other skin and soft tissue infections related to that. So that's just coming back to a summary of what we just talked about there. And if we move our spectrum outwards, we go out to what we call the moderate spectrum penicillins, which is amoxicillin or ampicillin, which is only available in the IV form. So this has good coverage against strep, enterococci, so the same as benzyl penicillin, but we also start to extend our spectrum down into the gram negatives. I will say, though, that there is increasing resistance to amoxicillin amongst gram negatives. So it's always, if you can, worthwhile checking the susceptibilities to amoxicillin. So amoxicillin is available as an IV and oral preparation, and ampicillin is available as intravenous only. And if you work in a hospital environment, some hospitals will keep one over the other. So the coverage, as I've just mentioned, is for strep, including strep pneumoniae. So amoxicillin or ampicillin is recommended for the treatment of pneumonia. And also, it does also cover Enterococcus faecalis. And so sometimes it's sort of used as part of this triple therapy for intra-abdominal infections. As I mentioned, it does have some gram-negative activity. These would have to be pretty sensitive gram-negatives, though, and there is slightly increasing resistance to amoxicillin, so it's worth just keeping an eye on it. If we extend our spectrum out even more, we have a drug like amoxicillin clavulanate, where it's got actually very broad spectrum of activity. It covers most of your gram positives, your sort of more sensitive gram negatives, and anaerobes. And the reason why it's able to have that effect, sorry, I'll go through in a moment. And then, the other similar one is intravenous piptazo, which actually is very, very broad spectrum. And the reason why they are so broad spectrum is that they're formulated together with something called a beta-lactamase inhibitor, which, if you remember the chemical structure slide that I went through a moment ago, actually it stops the beta-lactamase from the organism from breaking down the beta-lactam structure in the beta-lactam. And so we've got piperacillin tazobactam. The old brand name was Tazocin, but we of course recommend that people prescribe generically amoxicillin clavulanic acid, and the most common brand name for that is Augmentin. And so they really are very, very broad spectrum, as you can see from the graph before. Piperacillin tazobactam in particular covers against Pseudomonas, whereas amoxicillin clavulanate doesn't. And pip-tazo does also have coverage against ESBL organisms, but not these sort of more resistant escapum organisms. Moving on to the cephalosporins. So the cephalosporins, I suppose you can, that they're also a very diverse range of antibiotics. So you could kind of think about them in the same way as the penicillins. The penicillins have a very diverse spectrum. Similarly, the cephalosporins do as well. And essentially your clinical considerations for cephalosporins are almost identical to penicillins. They have the same sort of safety profile. You do obviously need to be mindful in patients who've got a penicillin allergy because there can be cross-reactivity. I suppose the only blanket rule for cephalosporins is that they, generally speaking, don't have any enterococci activity. There's sort of the Enterococcus is intrinsically resistant to cephalosporins, with the exception of one relatively new cephalosporin, which I'll mention at the end. Organisms can have sort of acquired resistance to it via beta-lactamase enzymes. So coming back to this graph, I've just sort of switched, because cephalosporins don't have any impact on enterococci, I've kind of just switched the order a little bit, just it's a bit easier from a visual point of view to look at this. So starting off with the narrow spectrum cephalosporins, these are an example, cefazolin and cefalexin are an example of what we call first generation cephalosporins, which have activity over these sorts of organisms. So good, like really quite good staph cover, good strep cover, E. coli, Klebsiella, and Proteus mirabilis. You might hear people talking about first generation, second generation, third and fourth generation. Generally speaking, as we move through the generations, we have broader gram-negative cover, but we do start to lose a little bit of the gram-positive coverage. Generally speaking, there are absolutely exceptions to that rule. So if we look back on the first generation cephalosporins, cefazolin is an IV formulation. Cefalexin is an oral first generation cephalosporin. Cefalothin is also there as well. I suppose it's slightly less commonly used than the other two. But cefazolin, for example, is really, really great against staph. It also has some strep cover, except it doesn't cover strep pneumoniae, so you don't use these for pneumonia. And they do also have some gram-negative activity. So generally speaking, cefazolin is the classic drug that we use for surgical prophylaxis, and they are a useful alternative to those narrow spectrum penicillins. For example, in someone who's got a penicillin allergy. Talking about second generation cephalosporins, we've got cefuroxime, which is an oral preparation, and Cefaclor, and sort of to a less extent cefoxitin, which is not really used that much. But cefuroxime and Cefaclor are very handy for respiratory tract infections, in people who've got a penicillin allergy. So they sort of cover the same organisms as these first generation cephalosporins, but they do also cover Haemophilus influenzae and strep pneumoniae. So they're really, really, really great drugs for pneumonia. Cefaclor in particular, I think, is sort of used quite a bit in the pediatric population. It's formulated really well in an oral suspension that actually tastes quite nice. So that makes things a bit easier in kids. And cefoxitin has additional Bacteroides cover, so it can be used in surgical prophylaxis, particularly for abdominal and gynae surgery. So that's just where we've come from, and moving on to a very, very well-known popular third-generation cephalosporin, which is ceftriaxone. So ceftriaxone has pretty good gram-negative coverage. It's sort of a bit more, it can sort of withstand some levels of resistance more so than cefazolin and cefalaxin, but you do start to lose some of your gram-positive coverage. So we don't really use ceftriaxone for kind of staph infections because it's just not good enough. But it does have very good streptococci cover, including strep pneumoniae, which is why it's used so much in pneumonia. There are quite a few different types of third-generation cephalosporins. So ceftriaxone and cefotaxime have really similar coverages, but of course ceftriaxone just has a really convenient once-daily dosing, which makes it quite popular, but it's used for severe pneumonia. It's got good penetration into the CNS, so it's used in higher doses for meningitis, for sexually transmitted infections, and also for intra-abdominal infections, particularly in combination with some other antimicrobials that have anaerobic cover. Ceftazidime is another third-generation cephalosporin, and the great thing about ceftazidime is that it actually covers Pseudomonas, which ceftriaxone doesn't. And it also covers all of the Enterobacterales, or the Enterobacteriaceae, or the enteric organisms. And from a gram-positive point of view, it has less activity against streptococci than ceftriaxone and cefotaxime. I won't spend too much time talking about the 4th and 5th generation cephalosporins, except to say that they have increasing coverage against some of their other more resistant organisms. And the interesting thing about ceftaroline, which is a 5th generation cephalosporin, is that it does also have MRSA cover. Moving on to the carbapenems. Now, the carbapenems are very, very broad spectrum. This is an example of the spectrum of activity for meropenem, and so meropenem in most hospitals will be a restricted drug. It has great gram-positive, gram-negative, anaerobic cover, Pseudomonas cover, ESBL, and escapum cover. It doesn't cover enterococci, but there's another carbapenem called imipenem, which does have E. faecalis cover. There is another carbapenem called ertapenem, which doesn't cover Pseudomonas, but it is also quite broad spectrum, and because ertapenem has got once daily dosing, it's quite useful in hospital and home outpatient settings. For the carbapenems, it has a very sort of similar mechanism of action, and the clinical considerations are also very similar to the cephalosporins and to the penicillins. So in my last 10 minutes, I'm going to try and go through the other antibiotics. And so I'm going to try and start off with some other antibiotics that are used for gram-positive infections, gram-negative infections, some that have effect over all of them, and also anaerobes. So clindamycin is a really, really, really useful antimicrobial. It's available in an IV form as well as an oral form, and it's got coverage against anaerobic organisms, staph, and strep. And the one of the really useful things about clindamycin, is that it's great in people who've got a severe allergy to penicillin, where you perhaps might not want to use a cephalosporin. And it also has effect against certain types of MRSA, something which we call community-associated MRSA, which is basically an MRSA that you sort of have a few more antimicrobial options compared with something like hospital-associated MRSA, which you can really only use your sort of very highly restricted antimicrobials for. of which one of those is vancomycin. So I'll also talk about vancomycin in this context too. So clindamycin has, so it's very useful in patients with penicillin allergy. Clindamycin doesn't have any gram-negative cover at all, so you need to use something else if you're wanting that broad spectrum of cover, particularly as an oral antimicrobial. It's primarily used for kind of skin and wound infections. It's also available in a topical preparation, which people use for acne and rosacea. And oral clindamycin is very, very, very well absorbed. It's basically got 100% bioavailability. So unless the patient has got something seriously wrong with their ability to absorb oral medications, we really use oral clindamycin because it's very similar to using IV. In terms of other clinical considerations, so oral clindamycin unfortunately has a very, very high pill count to sort of use it in the kinds of therapeutic doses that we would normally recommend. It's about 12 capsules a day. It's kind of like 3 to 4 capsules 3 to 4 times a day. So it can be, compliance can be a little bit of an issue. And in terms of side effects, probably C. diff diarrhea is the main one that we worry about. It's sort of one of the antimicrobials that's classically associated with C. diff diarrhea if it's, used on an ongoing basis without routine monitoring. And if you're administering the IV form of clindamycin, it's really, really important that you give it slowly because it can cause cardiac arrest if you give it too quickly. Vancomycin, which for those of you who work in a hospital setting is something that you'll come across a lot. It belongs to a class called glycopeptides, and there's another antimicrobial called teicoplanin, which belongs as part of that. It's really only used intravenously. And the good thing about vancomycin is that it has activity against MRSA. There is also an oral preparation, but the oral preparation is not absorbed at all. It's only used for its local effect as it's going through the gut. And so we use it as second-line therapy for C. diff infections. So it has activity against MRSA, but otherwise it's actually inferior against more sensitive gram-positives compared with a lot of the other antimicrobials. So vanc is not a good drug to use for susceptible gram-positive organisms. It is useful in severe penicillin allergy. Vancomycin needs to be dosed according to body weight. And so if you work in a hospital setting, you'll probably have some vancomycin guidelines. It does require drug level monitoring. So this is really important to take the drug level at the correct time and label that on the slip. It just helps the pharmacist and the doctor to interpret whether that drug level is correct. And there is something called a red man syndrome, which is not an allergy at all. It's just because it's been given too quickly. And so all you need to do is to slow down the rate of infusion and it goes away. Moving on to another antimicrobial, trimethoprim sulfamethoxazole. It's sometimes called cotriboxazole, and the classic brand name is Bactrim. So it's a sulfonamide antibiotic. So if the patient's got a sulfur allergy, you just need to take a bit more history and be mindful of that. And they might not be able to have Bactrim in that context. But its spectrum of activity, it's got really good staph cover. And one of the other great things is that it covers the sort of community-associated MRSA. So it's a really useful, particularly really useful oral option for that. It does have pretty good gram-negative coverage, including certain ESBLs, although of course that will depend on specific susceptibility results. It doesn't cover Pseudomonas though, and it does also have some coverage against these more resistant gram-negatives. So that's just sort of a summary of what I just talked about. So it's available in an IV and an oral preparation. In terms of side effects, probably the gastrointestinal side effects are the main ones that we're worried about. It does also cause skin sensitivity reactions. So I generally tell patients to cover up, avoid sun exposure, making sure they're putting on sunscreen, and also the hypersensitivity reactions too. Moving on to the gram negatives. So I'll talk briefly about gentamicin, which has really, really excellent gram negative coverage, and also an oral option, it's oral and IV, which is ciprofloxacin. So gentamicin is an aminoglycoside antibiotic. It's got really, really brilliant gram negative coverage. It's got sort of relatively lower rates of resistance, so it's helpful in you know, a setting, for example, like septic shock. It's also rapidly bactericidal, so it's very useful in that context. It does also cover Pseudomonas as well. Gentamicin is one of the drugs that has a concentration dependent kill, and so that's when we're looking at that time concentration curve, where the higher the concentration, the greater the ability it has to kill the organisms. And so it's typically used for empiric sepsis, gram-negative sepsis, pyelonephritis, and also used in synergy for endocarditis. The biggest downside with gentamicin is its toxicity profile. And so there are sort of three that we worry about. There's ototoxicity, which is sort of balance problem and hearing problems. The really disturbing thing about the ototoxicity is that it's very, very unpredictable and it is irreversible. Compared with nephrotoxicity, which means that in a lot of cases, quite elderly patients, and certainly anyone that's got renal impairment, we try and avoid the use of gentamicin. It usually is reversible though, generally speaking, and also neuromuscular toxicity. It's dosed according to body weight, but the important thing to say is it's dosed according to ideal body weight, not actual body weight. So if you've got a very obese patient, you just have to be careful that you're not going to overdose them. You need to calculate their ideal body weight or adjusted body weight based on their height. It's given once a day for gram-negative infections, but for endocarditis, where it's used for its synergistic effect, you give it like at a smaller dose multiple times a day. And it does require drug level monitoring if you intend for the course to go beyond 48 hours. Your pharmacist will advise you as to what those requirements are, but generally speaking, it'll be either a trough level, a peak level, or a mid-dose level, and it does require pharmacist input for dose adjustment according to those. So ciprofloxacin has kind of got the equivalent spectrum of activity as gent. It is also another concentration dependent bactericidal antibiotic, but unlike gent, we do need to be very mindful about the development of resistance. It's sort of not quite as hardy against that as gentamicin is. But generally speaking, it's got really broad gram-negative cover, including Pseudomonas, Acinetobacter and ESBLs. It also covers Legionella, but it has basically not very reliable gram-positive coverage. So we certainly wouldn't rely on it for that point of view. And in terms of clinical use, it's good for sort of enteritis, bone and joint infections, and urinary tract infections. In terms of clinical considerations, so really I would just it should only be used where other antimicrobials are not appropriate because of the issue of emerging resistance. We try not to use it in kids because it can have it can have an impact on the cartilage development. It does require dose adjustment and renal impairment. And in terms of adverse effects, probably the classic one, I mean, it's not very common, but I always warn patients about if they're getting tendon pain, particularly in their Achilles tendon, it can cause tendon rupture. And it can also cause QT prolongation. So from a drug interaction point of view, I'm mindful of other drugs that the patient might be on that also cause QT prolongation. For example, some of the antipsychotics and antiarrhythmic drugs. And for oral ciprofloxacin, it's ideally given on an empty stomach. Its absorption is impaired by the presence of calcium and iron. So we tell them things like to have yogurt and milk along in a short period of time compared with their oral dose of Cipro. And finally, last but not least, metronidazole, which is used for its anaerobic activity. And also for its antiprotozoal activity. It's a really, really great drug for intra-abdominal infections. It's also the first-line therapy for Clostridium difficile infections, empyema, if you've got contaminated wounds where you're worried about anaerobic organisms, and also for certain types of surgery. Its adverse effects, it's sort of not the most well tolerated antimicrobial. It can have sort of quite bad gastrointestinal side effects. Patients can complain of this sort of metallic taste, and we really don't want to be using it for prolonged therapy because it can have some hematological effects in the long term. And if the and obviously if the patient is already on an antimicrobial that has anaerobic cover, you don't need extra metronidazole on the top of that. One great thing about metronidazole is it has excellent absorption, and so you might not need intravenous therapy. And so the very last thing is another quiz. So of these 4 options, which one do you think has the broadest spectrum of activity? I'll just give you 10 more seconds for that. All right, Martin, we have a look at the answers. Very good. So piptazo, so piperacillin tazobactam is the correct response. Thank you. So in conclusion, antimicrobials are a really, really diverse group of medicines. It's difficult to learn about them sometimes, but obviously understanding antimicrobial spectrum of activity really helps to rationalise why certain antimicrobials are used for different infections. Thank you very much.
Thanks so much, Caroline. That's such a great presentation, and always so much to learn when I hear that. And I don't know if you can see it, but you're getting a lot of applause and thanks. Thank you.
Thank you.
From your responses here. I can see one person has raised their hand. In fact, we've got a couple of people who've raised their hands. If it's possible for you, I'm just in the interest of time and getting everybody finished on time, I'm wondering if you can either write your question down or hold on to it, pop it in the chat, and we might come back to you at the end of the workshop. There was one question that did come in the Q&A, Caroline, while you were speaking. Okay, and I can see Courtney's answered it, so that's fantastic. All right, we've got that. So if you just can hold your questions till the end of the session, that would be fantastic. And we are keeping track of them at our end. Okay. Now, our next speaker this afternoon, Caroline's sort of touched on it a little bit, but Belinda's going to follow through. It's Belinda Lambros speaking to us this afternoon, and Belinda is a nurse practitioner in infectious diseases and antimicrobial stewardship at the Peter MacCallum Hospital. She will introduce herself in more detail. She's also a clinician researcher at the National Centre for Infections in Cancer, and very exciting to have our nurse practitioner leadership person here with us this afternoon to talk about antibiotic allergy. Thanks,
Thanks, Fiona. Yeah, so thanks for the kind introduction and for the opportunity to talk today. I think Fiona's kind of answered exactly who I am. So I work with Peter Mac as a nurse practitioner with infectious diseases and antimicrobial stewardship, and also a clinician researcher at the NCIC. And yeah, Caroline's talk, whenever I hear her speak, it's very exciting and I always pick up something new. So I guess sort of the follow on to that is she was talking about penicillin allergies, and looking at those slides, it's kind of clear if you have a penicillin allergy, you're really at the back you're on the back foot when it comes to treatment, because you do need to go broader. And so trying to sort out what people's allergies are is really important. And that's kind of what we're going to go through today. So I'm going to be talking about what to assess, how to assess, when to assess the allergies, and where to go next, what the options are. Sometimes we can directly label, sometimes we could challenge low-risk allergies. Sometimes it's appropriate to refer for specialist testing. And so we'd really like to encourage everybody to sort of challenge these labels and think about it. So I guess this first one, I'd like to just have a bit of a raise of hands. When you are documenting allergies, what would you document? Whatever the drug name the patient says? Whatever medication I think they mean? Does anyone document the reaction type or when the reaction occurred, the reaction date? Or I don't kind of do it, I leave it for other staff. Excellent. So we'll sort of take a poll a little bit later. But when we are doing the nursing assessment, we'll assess patients for our allergy statuses. Because we're involved in the medication administration. When we admit patients or we go through their medication charts, we ask them what their allergies are. And if we're in the hospital setting, we often put a red armband on them to alert the team members to be aware of allergies. When we're checking medications, we check to see what allergies are listed. And when we go to give these medications to patients, we ask them, do you have any allergies? Quite often we'll hear those jokes, you know, only to doctors, hospitals or needles. But sometimes we do have a patient that hasn't got the red alert band because the printer ran out of the red ones. And so we use a white one instead. And so we'll fix that. And we think that, you know, that's a good job. We've done the right thing there. Sometimes we will come across a patient who has allergies, and the common medications that we hear, they often say the names that they know. Say, for example, endone, morphine, Pramen. But today we're here to talk about the allergies, the antibiotics. So Keflex, penicillin, or Augmentin is often what patients will tell us. We then duly make sure we're not giving them that medication. And at this point in time, our job is done. We've safely cared for the patient, ensuring they've received the appropriate medications and not given the ones that they shouldn't have, and that they're not allergic to them. But is our job really done? When a patient provides you with an allergy status, it's vital that we understand the details of those reactions. So adverse drug reactions, are they a true allergy, a side effect, or an intolerance? Quite often the type A adverse drug reactions, which are the side effects, they're often they're pharmacological in nature and they're not related to the immune system or genetics. Examples often are the gastrointestinal symptoms or neurological symptoms, nausea, vomiting, diarrhea, headaches, seizures, confusion. Sometimes there's depression or psychosis, LFT derangement when it's non-severe. It doesn't meet criteria for severe injury, or the drug-to-drug interactions can also be considered type A's. And then when you're looking at type B's, these are the true types of allergies, and they're classified into 4 types. And they're often grouped by timing and severity. So we think of them as immediate or delayed in terms of timing, and then severe or non-severe in terms of how bad the reaction was. So type 1 or IgE mediated, they're considered immediate hypersensitivity reactions. Type 2 are antibody dependent or cytotoxicity. They're often delayed reactions. Type 3 or other immune mediated are delayed hypersensitivity reactions as well. And type 4 or T cell mediated delayed hypersensitivity. Oh, I'm sorry, I've gone too fast. Let me just go back. So there's a natural history process where prior exposure to the antibiotic has often happened, and the reaction becomes worse with each subsequent exposure to the medication. And that's because of that immune memory. the immune system memory. So when you are going through the severe or non-severe and timing, the common questions that we think about, we talk about, when we're talking about severity, what actually happened to the patient. Use the patient's own descriptive words because they're very helpful in determining what type of reaction occurred. But we're also looking for the objective signs as much as possible, not just the patient's perception of the reaction. So for example, say the patient had an itch and they said it was 10 out of 10. It was really uncomfortable. They were sort of ripping their skin off. It was unbearable, but they didn't go to the GP for a few days. No treatment was needed and there wasn't any rash. Whilst this is, important information, as part of the process, the questions around treatment and hospitalisation should really guide you in terms of the classification. The second point is around timing. There's two parts to timing in terms of how soon the reaction occurred after taking the antibiotic. I've done it again. How soon the reaction occurred after taking the antibiotic, but also how long ago it happened. So was it within minutes, was it within the first couple of hours, or was it 2 or 3 days later, or was it actually a week or two after the course of antibiotics had completed? And in terms of the timing, how long ago was it, this year? Is it this current admission? Or was it 5, 10 years ago, 20 years ago? As a child, they have no memory, as a toddler. And then we talk about tolerating. So what antibiotics have they tolerated since the reaction? It's really important to look for those trade names because they may say that they've got an allergy to penicillin, but they've safely tolerated, and that was as a child, but then they've safely tolerated amoxicillin because it's a different medication name. So looking for those pieces of information is really helpful. Often we can track down information from GPs and other healthcare facilities to determine what they have had since that time. And fortunately, the electronic records these days are making this a little bit easier. But essentially, once the reaction occurs, it's kind of like that time zero and we start again. It resets the clock to determine what they're okay with. So when you are doing this, it is very helpful to use a validated tool, and the group at the Austin have validated this tool as well as at Peter Mac. And this is quite useful to go through, and it looks like quite a bit of information, but it really does break down those symptoms of the reaction. And the first column is looking at the dermatological, so all the skin type reactions, and they are sort of grouped into timing and severity. And then the middle column looks at the respiratory or the systemic reactions, as well as the hematological reactions. So blood, factoring in blood counts and things like that. Unknown reactions is on the top of the right, and then the renal, liver impairment, or neurological or gastrointestinal or other reactions. And it is graded in terms of severity. So no risk are often the type A adverse drug reactions, where there's no real risk and they're appropriate to direct delabel. The low risk patients are the patients that would tick the green box, and they're unlikely to be severe and or significant. The moderate risk and the high risk patients are the ones in the orange and the red. So whenever you are classifying a reaction, always go to the most severe type of reaction. And so this is the tool that I'm going to use to go through some case studies to illustrate the different types of reactions. And it is a validated tool that has been published, and it was by Misha Devshan et al. And it is quite a useful tool. So what would you do when you go to put on the red label for the patients in these cases? So we're going to go through a couple of the moderate to higher severity type reactions now. So thinking about Jenny. Jenny is a 56-year-old teacher who was admitted for investigation for shortness of breath, fevers, and feeling generally unwell after returning from school camp. She describes developing welts, some tongue swelling, and some shortness of breath following her second dose of amoxicillin more than 20 years ago. She'd previously had this with no issue, and the reaction seemed to occur shortly after that second dose. She was rushed to the GP, who gave her something in her thigh, a tablet, but she responded quite quickly to this treatment and went home afterwards. And she's safely taken ceftriaxone since without issue, but has avoided other penicillins in general. And so going through that sounds pretty severe. So this is a type B ADR, an immediate. And the symptoms of that often are that urticarial rash, so that hives or welts, the tongue swelling, and that photo obviously illustrates that quite well, but there are different variations of that. They often have bronchospasm or shortness of breath, anaphylaxis, hypotension, and collapse. So these are the patients that feel really unwell really quickly. And so in that, when we're looking back at that tool, she'd be classified as orange. So it was greater than 10 years ago, but she did have that tongue swelling, that angioedema. She did have those wheals and hives, the urticaria, as well as some respiratory compromise. And so she would be someone that's appropriate to be referred to a clinic to have that assessed. So the second case study that we'll go through, Jacob. So Jacob's a 30-year-old carpenter who recalls a history of developing a whole body itchy rash within about an hour of taking his first dose of Keflex about 5 years ago. He didn't need to go to the hospital, and it resolved upon taking an antihistamine that he had in the pantry, but he's avoided all penicillin since. And he presented to hospital for an infected traumatic wound. And so in there, I've really sort of highlighted, what the reaction was, the timing of the reaction, the treatment that they had, and the antibiotics tolerated since. And that's the theme of how we really do classify these reactions. And so for him, often it's a type B adverse drug reaction. Again, it's immediate, but this one would be considered as non-severe. And it had an urticarial rash with no other symptoms or features of severe features. And it's often within that first couple of hours. And so here, that would be considered an immediate diffuse rash, and it's quite itchy and immediate, but within those 2 hours. And so that would be classified as an orange reaction. Farmer Dan. So Farmer Dan is a 57-year-old cattle farmer from Gippsland who lives with his wife, Kathy, and 3 adult children and a couple of grandchildren. His reaction was post an IM penicillin injection. He describes a rash to half his body after an IM penicillin in the 1980s. He was generally pretty unwell, and the GP did manage the reaction. It took a couple of weeks to resolve, and the skin blistered and peeled off. He was treated by that local doctor, but didn't have hospitalization because, cattle farmers don't have time to go to hospital, love. Some blistering and some desquamation was evident, and it's not really clear what he tolerated since. And this is a patient who was planned for stem cell transplant. So reaction is listed there. Timing was definitely delayed, and it was managed by his GP, but probably wouldn't have been managed by his GP if he wasn't those typical tough rural guys. And so we're talking about these type B adverse drug reactions, which are delayed, but it's obviously quite severe. When you hear the word blistering, peeling, or shedding of the skin, you can see that in that top photo. And they're often severe, and they do have systemic reactions as well. When he said he felt pretty unwell, that's not something that these guys admit to very easily. You're often quite concerned about scar, so severe cutaneous reactions, or an SJS, so a Stevens-Johnson syndrome, or the TENS, or a reaction called AGET, which is a pustular drug eruption. They often include hematological symptoms such as deranged platelets or neutrophil counts, hemoglobin, or eosinophil counts. You need to think about DRESS. Other potential immune or antibody-mediated reactions are often less common and quite delayed. They can be the severe renal injury that could be acute interstitial nephritis, or the DILI, so the drug-induced liver injury. And often there's a fever as well, not associated with the underlying infection that you're trying to treat. They often require an expert infectious diseases allergy consultant or an immunology review for current as well as future management in these patients. And they often have that when you've got the organ dysfunction, you'll see the limb swelling. And so in there, we'd classify this one as definitely red. So rash and mucosal ulceration with the blistering and skin shedding. And so what do we do for these patients? These are the patients that should be referred to immunology or to antibiotic allergy specialists, and they can assess, test, and provide education and information to the patients on their allergy status, assessment and clarification of what they can have and what they can't have. And also we sort of determine, some antibiotics they'd be able to have, but others they can't. And then if all goes well, we would then proceed to oral challenges. So the skin prick testing is kind of like the screening test. And the way we do that is we put histamine, which is a positive control, and then normal saline, which is a negative control, and then screening for some penicillins, or depending on the medication that we're looking at. And then we read that after 15 minutes, and we expect the positive to be positive and then the negative to be negative, and then we compare the others to those. And so if that screening test is appropriate, then we would move on to the intradermal testing, and that's where we essentially put 0.2 of a mil of the medications underneath the skin in a grid-like format, and we tease out the whole penicillin family. As well as some cephalosporins and some carbapenems if it's appropriate, depending on the reaction. Sometimes it's appropriate to do some patch testing, and so that's where it's often in delayed reactions, but they're not as low risk as the ones that we could do for oral challenges. And so that's where you have an antimicrobial cream, and you place the patches on for 3 days and have that read and removed. And then after all of those, we would then move to oral challenges. And so that's where you complete a small component of the medication. Sometimes it would be a split dose, so we use liquid formulation. Other times we would use a tablet, and then they're monitored in a supervised environment for sort of 1 to 2 hours afterwards. But obviously in the lower risk ones, we can go straight to that. And I've gone through all that. So then just to let you know, Farmer Dan was a real patient of mine, and this is what things look like afterwards. So his skin testing was quite positive. The itch and the rash was pretty uncomfortable, but typically being Farmer Dan, he did take some it took a while for him to take the antihistamines and the relief. And interestingly, some of his family members have also had some penicillin allergy testing as well. We rated for this to all settle down, and proceeded to oral cephalosporins because we could see quite clearly that he had a beta-lactam ring allergy, but no cephalosporins lit up, so that was good. And so then prior to his auto transplant, we were able to give him back some cephalosporins. And so it's really important to sort of document what happened, and make sure that you've got those allergies nice and clear going forward. So low or no severity allergy phenotypes, we'll go through these now. So Bree is a 42-year-old IT expert and diagnosis of breast cancer. She had an antibiotic allergy label of amoxicillin clavulanic acid, but she described gastrointestinal symptoms, including nausea and loose bowel movements, when she was prescribed Augmentin about 23 years ago for a persistent chest infection, and has avoided penicillin since. So she was a type A reaction, and so we were able to educate her around signs and symptoms of side effects, and give a good management plan if those were to happen, but safely remove her allergy label. So she would come down as a white. And we often provided them with written information as well as the education. And we also send letters to GPs with the outcome, so that then they can, so that everyone in the team is well known as to the outcome. And then our final case study is Charlie. So Charlie is a 76-year-old gardener who was admitted with a penicillin allergy label. Thinks he had a bit of a rash, but was unclear of any other details. His mother told him that he should avoid penicillins, and being the good son he was, he hadn't had any since. This is often the most common reaction that you'll hear. So it's either unknown in timing or delayed, and as a child. And they'll often describe it as measles-like rash, which can be nubilliform or maculopapular, but no severe features. And so in those ones, it's that childhood exanthem often, and they are green and good to go for oral challenge. And so there are some oral challenge protocols, and it's been validated and published. And essentially the lowest criteria are unknown or greater than 10 years ago. Type A adverse drug reactions, where patients require a little bit of convincing that it's not a true allergy, and the childhood rash or greater than 10 years ago with no severe features. So Charlie was given a 250 milligram dose of phenoxypenicillin and monitored for 2 hours for any symptoms of signs of reaction. He was cleared safe for all penicillins and delabeled. His GP provided with a detailed antibiotic plan, as well as himself, so that he can take that to any additional places that he's going. And when he was recently admitted after that, he convinced another patient to have a chat to us, because we were a good bunch of people who took away his red band. And he had a 98-year-old mother in the nursing home, and he quite happily told her that she was quite wrong, that he didn't have a true penicillin allergy anymore. So tying it back into our case that we were talking about, Mr. Ross, just in quick summary, 96-year-old male, sepsis, urine source, and no known drug allergies. On day 1, he had some ceftriaxone. Day 2, he had some meropenem. And then day 6, he was switched to the Bactrim BD for 3 days, and then 1 tablet a day for 6 days. He presented to the GP on day 8, and he talked about some nausea and loose bowels, and it was the last few days of the course, but he completed that course, but not keen to take it again. So Arjun, if you can just launch the poll, I'd love people to put what they think his allergy should be listed as. Just give people a few seconds. Okay, what do you reckon? Have we got enough?
So we've got 23%,
Okay, give it another
26%. So yeah, a few more seconds.
Happy to close it when you think it's ready. So options are immediate severe, immediate non-severe, delayed severe, delayed non-severe, a type 1 adverse drug reaction, or list as no known allergies and education around the management of symptoms should they occur.
Okay, so I'll close it in 10 seconds.
Thank you. Beautiful. Everyone gets a gold star. So yes, definitely educate the patient that it would be appropriate to take this medication if it was required again, and thinking about side effects and managing those. So back to this. So in summary, nurses are, as we said at the very beginning, nurses are very well placed to provide some antimicrobial stewardship support for our patients, and assessing allergies is a great resource. Excuse me. When you are assessing those reactions, think about timing, severity, and what's been tolerated since the reaction. Please document your assessment and discuss it with your colleagues, and suggest referral to clinics if appropriate, and delabel and educate your patients. So there are lots of resources. We've got a Safer Care Victoria program that's going around at the moment to try and reduce penicillin allergies and help hospitals set up oral challenge and direct delabel programs. And we've got lots more information. And as Caroline mentioned, Jason Tribbiano, his centre is the Centre for Antimicrobial Allergies, CAR, and that's a great resource and got lots of information and protocols on there. So that's it. Thanks, team. And I guess, yeah, just very briefly, I'd love to acknowledge all of my patients who were involved in this story.
Thanks, Bill. Presentation and more applause coming through. I am going to move on to introduce our next speaker, Nadine, pretty quickly, just because I'm watching the time and I'd really like to be sure we get through Nadine's presentation and have time for questions. So Nadine is, most of our presenters are from Victoria today, but Nadine is actually from South Australia. And she is a senior pharmacist and also the manager of the National Antimicrobial Utilisation Surveillance Program that is based in South Australia there. And I mentioned the AURA report earlier on, and the NORS program contributes data for AURA. So Nadine is going to talk to us about disposal of antimicrobials. Thanks, Nadine. I can see your screen, Nadine, but I'm not sure if we can hear you. Just
there we go.
There you
go. Can you hear me now?
We can.
Thanks, Fiona. So before I start today, I just want to declare that I'm not an expert on waste disposal, but Fiona's given the introduction of what I do. So I manage the National Antimicrobial Utilisation Surveillance Program, and stewardship includes, it's not only about appropriate usage, but it's also about appropriate disposal. Going forward. So I'm going to talk today about some of the main causes of antimicrobial environmental pollution and what we can do as healthcare professionals about safe disposal, education and advocacy for safe disposal policies and pathways. For those of you who heard Kaz Thursky speak at the symposium on Friday, you would have heard her speak about the importance of an ecocentric approach to stewardship, rather than just focusing on how humans, around the impact to humans. It's also about how the usage in animals and the environment ultimately impacts human health. But we should also be focusing on the impact on animals themselves and on the environment. There should be equity between all settings. I'm going to now just give the example of chemotherapy. So this is a bag of chemo, and I got this picture off the internet, so I know it's got a patient name on it, but it was on the internet, so I've just taken it from the internet. Imagine the patient has passed away and the chemo is no longer required. What should you do with the infusion bag of chemo? So we wouldn't dispose it. We would dispose of it in the hazardous waste bin because it's labelled cytotoxic. We wouldn't even consider tipping chemo down the sink. But why is that? So there's a hospital policy telling us not to. It's labelled as cytotoxic and to be disposed of properly. We also know it's unsafe to tip chemo down the sink or expose other people to the effects of the chemo. And also the hospital actually provides a clear disposal pathway and makes it easy to dispose of it appropriately. But what about for antimicrobials? So most hospitals do have a policy for disposing of medicines, but very few, especially that I'm aware of, actually specifically refer to safe disposal of antimicrobials. Antimicrobials don't need to be labelled as cytotoxic and disposed of properly, even though they do kill cells, they kill bacteria cells. we as antimicrobial stewards are very aware that it's not good to expose people to antimicrobials when they don't need to be exposed to antimicrobials, but a lot of other people are not so aware. And there's often no clear disposal pathway in the hospital specifically for antimicrobials. So now I'm going to do a little poll. Arjun, I don't know if you can set that up for me, but I'm just wondering if your hospital or workplace has a policy on the safe disposal of antimicrobials. You've got a bit of time to answer that one. Yeah, 10 more seconds. Yep. So, yep, that's really interesting. A lot of people are unsure, but most people say there's no policy in their workplace. And I'm not surprised because from my sort of asking around, that seems to be the sort of the situation we're in. So moving on, antimicrobials enter the environment mainly in three main ways. There's a number of ways, but there's three main ways. So there's the use of antimicrobials in animal feed, in food-producing animals, for example, pigs, although we're getting better at that. There's the improper disposal of antimicrobials by healthcare facilities and also by households, so people in the community. And also the antimicrobials excreted by humans and animals through urine and feces. Improper disposal of unused antimicrobials is often overlooked as a driver of antimicrobial resistance, and that's largely because there's a lack of awareness in the community about the impact to the environment. And hospital wastewater contains a really high density of antimicrobial residues, so active drug and metabolites from urine and feces, but also inappropriate disposal of unused drugs. And at the same time, there's a high concentration of antimicrobial resistant bacteria. So there's lots of MRSA and VRE getting washed down into the wastewater, along with antimicrobial resistant genes. And that's all swirling around together. As I mentioned earlier, I'm not an expert on wastewater management, but from reviewing the literature and also from other publicly facing documents regarding wastewater, in general, most wastewater treatment facilities are not equipped to fully remove antimicrobial drugs, and nor do they remove antimicrobial resistant genes. So this, of course, increases the risk of transmission of antimicrobial resistant genes to new bacterial species. Oh, sorry, I'll just go back. But inefficient wastewater infrastructure may actually be a greater contributing factor to antimicrobial resistance in healthcare than the actual level of antimicrobial prescribing or usage. There's a number of studies looking at pharmaceuticals in fresh water, and this is an example from Melbourne, done 4 years ago, so just before COVID. They looked at the level of pharmaceuticals in 6 streams near Melbourne, and they measured the level of 98 different drugs in filter feeding invertebrates in these streams. And there were many antimicrobials that they didn't test for, but they did test for 98 different ones, and of that there were at least 10 antimicrobials in there, and fluconazole was one of the top 5 most frequently detected drugs, and this was in freshwater streams around Melbourne. There are many reasons why antimicrobials need to be discarded or become waste, and we need to dispose of them. So prescribed antimicrobials are ceased or changed, and that's often due to adverse reactions, changing from empirical therapy to targeted therapy, and obviously IV to oral switch. Patients are non-adherent and just pop them in their cupboard at home, or patients recover and don't finish the course. They pass away and it's no longer needed, or sometimes an excess quantity is supplied. And then we've got expired stock, and that happens frequently in for low use antimicrobials or in remote settings. And also there's returns due to prescription error. Antimicrobial waste due to expiry is quite common in rural and remote hospitals where the overall usage is low. We actually looked at the expired stock in 12 rural and remote hospitals here in South Australia over a 3-year period. And for some of the, although the usage is quite low for these small hospitals, the proportionate wastage due to expiry was actually relatively high. For some of them, it was up to, for some of the antimicrobial classes, there were up to 25% wastage. And in some of these cases, they're so remote that returning the stock to the metro the metro setting is actually more costly than just replacing it. And so they often expire. Antimicrobial disposal is actually all about definitions. So when hospitals have policies for disposal of medicines, whether antimicrobials are actually disposed of appropriately is often about how they're defined in those policies. And in many, if not all cases, hospitals don't specifically refer to antimicrobials in their policies. In fact, the Australian standard for the management of clinical and related waste doesn't actually specifically refer to antimicrobials either. So how should we define an antimicrobial as waste? So the general waste is when it doesn't pose a threat or risk to public health or safety, and it can go into landfill. And most hospital policies and even policies in other settings like aged care, they often just refer to antimicrobial waste as general waste. Clinical waste is only when there's blood or body fluids associated with the waste, or sharps, those sorts of things. And hazardous waste is where it's potentially, the actual definition is where it's potentially dangerous or harmful to human health or the environment. And so antimicrobials should be falling under the definition of hazardous waste. And what about patients? What do they actually know about waste disposal? So there's various population surveys published, and most illustrate a lack of consumer awareness. There's this one from 2009. It was a New Zealand online survey, and there were 452 respondents to this survey. And depending on the formulation, up to about a quarter, less than a quarter, were actually returning their unused medicines to pharmacies. And if they were liquid medicines, more than half of the respondents would tip them down the toilet or the sink. This was very similar to an Australian general population survey in 2016 as well, where 80% didn't know what to do with unused medicines. Some of you will be familiar with the RUM project. Oops, did I go too far forward there? Returning Unused Medicines Project is a national not-for-profit company funded by the Commonwealth Department for Health and Aged Care. All community pharmacies can accept unused medicines, and there's no cost to consumers. Medicines returned via the RUM project are disposed of in high temperature incineration, and so the byproducts of it's really high temperature incineration. So the byproducts of that incineration is mainly carbon dioxide and water. There is some inorganic material that is just ash, but it is a much more environmentally friendly way of getting rid of unused antimicrobials. And as of July 2020, animal medicines can also be returned to pharmacies via the RUM project to dispose of pet medications. And they can take doses for animals can be up to, they're much bigger, obviously, and so the doses for animals can be much larger, but they can take up to a litre of liquid that can be disposed of in a RUM container. So what can we do? We can educate patients about the safe disposal in the community and tell them about the RUN project, and inform patients about the risks to the environment when antimicrobials end up in the wastewater via the sink or via the toilet. We can encourage them to return antimicrobials to the local pharmacy, including their unused pet antimicrobials. And from the survey, the general population survey that I spoke about just before in 2016, although 80% didn't know about the RUN project, 92% said that they would use it if they knew about it. So there's a big role there for education. What about in hospitals and healthcare facilities? You can ask if there's a policy on safe disposal of antimicrobials, and if not, you can advocate your management for guidance or a facility-wide policy, and you can return unused oral antimicrobials to the pharmacy. And definitely don't put antimicrobial liquids or infusions down the drain, and really question management if you think their disposal practices could be reviewed or improved. There's a real role for nursing staff to advocate for antimicrobials to be considered as hazardous waste and disposed of accordingly. So if we go back to our case study, Mr. Ross, so he was on meropenem, 1 gram every 8 hours, and say you prepared the next dose for him, you drew it up into a 200 ml bag, and it's stable for 3 hours, so you were anticipating the next dose. What should you do if you had prepared it just before they changed him over to orals? What should you do with the unused infusion? Well, if there was another patient that was on 1 gram meropenem, that would be my first option, that you could just use it for the other patient if it hadn't been used for Mr. Ross. But if there was no option, you would put it in the hazardous waste for incineration, and do not drain the infusion bag down the sink. And then, say for example, he was given the rest of a hospital pre-pack of his when he changed over to Bactrim DS. So if he was given the rest of the 10 tablets in the hospital pre-pack, and they gave him another prescription for 10 tablets for the rest of his course, he would be left with 7 tablets left over, because he would have had the 6 tablets for the 3 days, and then another 7 tablets. He would have had 13 tablets that he needed. He'd have 7 left over. So what should he do with that, with those leftover tablets? We should be educating him to return it to the pharmacy for safe disposal through the RUN program. So I've sort of rushed through this pretty quickly today to catch up some time, but in summary, don't rush to flush is the message. We've got a role as health professionals and as antimicrobial stewards to educate patients, especially to return their unused drugs to the pharmacy, and not tip liquids down the sink, and just teach them about the environmental pollution of antimicrobials. And nurses have got a hugely powerful voice to advocate management to facilitate appropriate disposal of antimicrobials in the hospital environment, especially IV antimicrobials and other liquids. So thank you.
So much, Nadine, for that presentation. It's quite thought-provoking, and again just really brings back some of those comments that I made at the beginning about the importance about thinking about stewardship, not only from the time of assessing a person, but right through to that, and when you're thinking about educating people about all that antimicrobial use. So many opportunities there for nurses in their role, educating, communicating with people as a member of the team. Okay, so that wraps up the formal part of our session for this afternoon, and we now have some time for questions. What we had planned to do in this session was wrap up with our discussion about Mr. Ross, to let you know what happened to him. Now, some of our presenters have talked about him along the way, but I'm wondering, Stephen, if you would like to quickly take us through what happened.
Certainly.
And I'll just introduce Stephen to you. And Stephen, for those of you who don't know him, is a clinical nurse consultant with the Queensland statewide antimicrobial stewardship program. And yes, a presenter from Interstate. And once Stephen's run through, I'll introduce you to some of our other panelists and attendees, and we can have some questions and answers.
Can you see that in full display, or is that presenter mode?
That's in presenter mode for me.
Oh, apologies.
Yep, perfect.
Great. Okay, so going back to Mr. Ross, in terms of his clinical assessment, he had some formal bloods taken. He had one set of blood cultures and some point of care bloods. The CG4 showed the lactate was 1.5, and he had some renal impairment on his CG8. So the initial diagnosis by the doctors was urosepsis. We've discussed that it really should be sepsis with a likely urine source. He had an IV cannula inserted and was commenced empirically on IV antibiotics of 1 gram of ceftriaxone once daily. And he had some gentle fluid resuscitation of normal saline at 83 mils an hour. On day 2, he remained unwell. He was still febrile. He had an IDC inserted on day 2 and a catheter specimen of urine sent. The blood culture results came back positive at 6 hours with an ESBL producing E. coli. He had the empiric therapy of ceftriaxone was ceased, and he was commenced on directed therapy based on susceptibilities of IV meropenem, which is 1 gram 8th hourly. His formal bloods came back, which showed he had elevated white cell count and an elevated CRP. On day 3, he remained unwell, still confused and febrile, although his blood pressure was improving. He continued on IV meropenem. The review of the catheter specimen of urine was done, and it was consistent with the blood culture result. So likely bloodstream infection secondary to an E. coli urine infection. On day 4, he was slowly improving now. He was now afebrile and normotensive. His confusion was resolving, and he was now eating and drinking. The treating team discussed the case with an infectious diseases specialist who advised to closely observe the renal function, given the antibiotics that he was on, and aim for an IV to oral switch when clinically appropriate, and with a recommendation that oral Bactrim be used based on the blood culture susceptibilities. On day 5, slow improvement continued. They repeated the bloods, which showed that the kidney function was slowly improving. And on day 6, there was still a continued improvement. Had been afebrile for greater than 24 hours. So the decision was made to switch from IV to oral therapy of Bactrim double strength twice daily. On day 7, the patient remained well, was eating and drinking, and was discharged home into the care of his daughter with the discharge medications of Bactrim double strength to complete a total of 14 days combined therapy of hospital and at home. There was a discharge letter given to the patient and his daughter, and also one sent to the GP with a recommendation to complete the course of oral antibiotics as prescribed, to follow up with a GP should he can experience any foul-smelling urine, pain or discomfort on urination or fevers, and if he had any concerns to present to the emergency department. So in terms of the antimicrobial stewardship aspects of the case, so the patient did have a documented acute advanced resuscitation plan, and they discussed with the daughter and the patient this again on admission, and it was deemed that that was still appropriate and IV antibiotics were appropriate. The patient did present with signs and symptoms of septic shock. There was no documented use of a sepsis clinical pathway. There was also only one set of blood cultures taken, although it was taken prior to the antibiotics being commenced. And I might just ask Arjun if he would be able to pop up a poll question based on blood cultures. So which factor or factors do you think most influence the timing and number of blood cultures taken from a patient with a suspected severe infection or bloodstream infection? So lack of knowledge, so one set is adequate, lack of clear instruction on the timing and number of sets of blood culture to take, don't want to delay the administration of antibiotics, other priorities in his clinical care would take precedence, or poor or difficulty getting IV or venous access to take the blood. Just give that 30 seconds. Okay, Arjun, might see what the result of that is. Okay, very interesting. Thank you. Okay, so the empiric therapy for the diagnosis of urosepsis was not in line with therapeutic guidelines as first line treatment. So gentamicin and ampicillin as first line, but often with elderly patients and patients with acute renal failure, so you had a EGFR of 32, often they will err on the side of caution and they use the second line, which is ceftriaxone, 1 gram. Now, the patient was in septic shock and no fluid bolus was given, but the patient did have a history of congestive cardiac failure. So that will be a reason for using gentle IV fluids. There was an appropriate switch to directed therapy based on blood culture susceptibilities on day 2. For reasons I'm not sure, the catheter was not inserted until day 2, but a CSU was collected. It was collected after antibiotics, but there was an appropriate review of the results, and it was consistent with the blood culture results, so there was no need to amend antimicrobial therapy. They did seek appropriate specialist ID advice on day 4 and got advice on IV to oral switch and duration of therapy. Now, the patient was slow to improve, so that may have affected, well, that would have affected the length of intravenous therapy. Often with elderly patients with multiple comorbidities, they respond more slowly to infections, but there was an appropriate IV to oral switch. The patient was eating and drinking and been afebrile for greater than 24 hours. And there was clearly documented advice on discharge to the patient and the carer and to the GP about the antimicrobial plan, what to look for, what to look out for, and what to do if concerned. So I think now is an opportunity for comments and feedback on the case study, but also on the presentations in general.
That's right. Thanks, Stephen. So yes, by all means, put your questions and answers about the case study into the chat. Be happy to answer them. I'll take this opportunity to introduce Professor Kaz Thursky, who is the Director of the National Centre for Antimicrobial Stewardship and who's come in to say hello to the workshop this afternoon. Kaz?
I'm so sorry when I've missed the first half. I had to get on a plane to go to Adelaide for this whiz-bang new CDC consultation. Anyway, we'd be very happy to know that I think it's going to be really important looking at both infectious and non-communicable diseases and really be community facing. So that was all good. I've got the great pleasure to say that I work with many of the people on the screen today. So like the Brady bunch of people that I actually work and mentor and sponsor. So I'm really happy. I hear that it's been going really well. And I do encourage you all to reach out to any one of these amazing people, and also to look for opportunities for collaboration as well in your organisation. Shout out, I'm not sure whether Alison highlighted in her talk, maybe she didn't, but she's actually, did you talk about your PhD, Al? Good. So we're going to be really looking for some volunteers to participate in some of her qualitative work as well. And of course, I've got a strong interest in implementation of sepsis pathways and the implementation of the clinical care standards in sepsis. So I'm always looking for people who want to put their hand up and participate in some of the work that NCAS is doing. So thank you to all of you that have put this amazing program together.
Thanks for that, Courtney. Yeah, Kaz, sorry, looking at Courtney's picture and thinking Kaz. Look, yeah, it certainly is a great group of people. I would like to just highlight, just make sure that we answer a couple of questions. Arjun, could I put over to you? I believe there was one from Gemma earlier that we haven't spoken to yet. And for some reason, I just at this very minute can't see the Q&A box on my screen.
So no worries. We had a question from Gemma about antibiotic irrigations in the operating theatre, and Kaz responded to that to say, yeah, well, Kaz is online. Kaz, you can address that. So about antibiotic irrigations in theatre.
Yeah, look, the intraoperative use of particularly antimicrobials, and we didn't talk about this, Nadine, today, but the use of antimicrobials in cement, in wound irrigation, in breast implant surgery, it's actually formally included in part of this 14-point plan. For all our stewards, we're always quietly horrified by the whole thing, because the evidence base is somewhat slim. And the use of these sorts of agents in theatre are very interesting and hard to investigate, and they're often not documented very well either. And I have tried to find out what is happening to them in my own hospital, and I've asked my pharmacy team to sort of investigate. But it's really a bit tricky. So maybe that's something that we do need to take it the next step, Nadine, about finding out exactly what's going on. Maybe we can include that as part of the NAP survey next year.
Yeah,
so it's a really good question, Gemma.
I actually missed the first bit of the question. So was it about disposal, or was it about?
It's about what happened to.
Yeah, what happens to it? Yeah.
They just tip it down the sink. I have a terrible feeling that that's probably what happens, because they mix it up with saline, 2, 3, or sometimes even 4 antimicrobials and swish it around. So then they would suck it out, which means it would just go wherever that goes.
Into the wastewater.
Yeah.
Yeah. I think documentation is like the first major step, so that we've got some idea of actually what's going on at the moment. There's a lot of that's not getting documented at all. But yes, I agree with you, Kaz. It would be a great place to start.
I'm not sure how many of the people online have participated in the NAP, so maybe we could have a show of hands to see. I know obviously there's a few pharmacists, but the nursing staff, have you ever participated in the NAPs? Is it something that you'd like to, do? Because I think it's a wonderful way to learn about quality use of medicines and understanding how to use antimicrobials. And so there's quite a few hands going up, which is fantastic. The SNAPs, which is a surgical one, is quite commonly done in the private hospital, and that one you can capture the intraoperative use of antimicrobials. It's the hospital one, which the point prevalence is less suited to that sort of audit. So the SNAPs for sure is something that could definitely be done. And the other thing to say is, and working with Belinda prior to her coming across as our nurse practitioner at Peter Mac, did work in GI, right, Belle? And so nurses have that unique opportunity to often have quite good relationships with surgeons and registrars. It's very different. It's a different relationship than, say, the more junior medical staff have, and they often work with them for a long time and they become they're trusted relationships. And so I would take advantage of that in your own organisation if you are interested in actually doing a surgical audit and say, look, would you be happy for me to do a surgical audit? I'm really interested in looking at our breast surgical patients and I'm happy to do it, and I'll do 30 and I'll feed it back at your meeting. You know, it's a really nice way to, you know, participate in the quality improvement activities of the surgical unit.
Thanks, Kaz. I will come back to another question, and I'm not sure if I've got the other Gemma here, but there was another question around the issue of respiratory viral infections. And I guess this will be pertinent to all the people, not only who work in the hospital settings, but those in the audience who are working either in primary care or in the aged care setting who are still with us. So the question is, how can we better advocate that antibiotics are not needed in our nursing roles? And part two of the question is there a role for viral testing to support reduced antimicrobial use? So I'm wondering if we might go to part two first, and perhaps Nick or Kaz might answer the role of viral testing.
Nick, you can answer.
Put you on the spot.
Yeah, I mean, it's always harder, I think, in the community than when you have more resources at your fingertips when you're in hospital. I think a lot of it depends on the patient cohort you're dealing with as well, as to how vulnerable they are, whether they're immunocompromised. Again, we deal with a very different subset of patients here. Many are on sort of chemotherapy or a neutropenic, and you just don't have that safeguard of holding off on antibiotics. But I think, you know, in the community, if you have someone who is as well and has, you know, a compatible symptom history with a viral illness, runny nose, sore throat, you know, in an appropriate season, and I think it's often reasonable, and many GPs do use that judgment to say we're not going to give antibiotics. And I think it probably wouldn't be a reasonable use of resources to do extended viral testing, but of course COVID being an exception to that at the moment. So no, I think in answer to the question, I think for the community, it is tricky, I think, without just doing a pan-viral swab on everyone. So I think it's about stratifying the patient group you're dealing with and looking at the history carefully.
I think what we've found in our GP work is that what is happening is that the GPs are wanting information about what viral epidemics are going around. So if they know in their suburb that there is a RSV outbreak, then they know that kids coming with asthma and cough and bronchiolitis are most likely to be having viral infections. So one of our colleagues, great colleagues, Jim Buttery, who's a paediatrician informaticist, has got this fantastic program that he's going to be hopefully getting up called Snot Watch. And Snot Watch is going to be able to provide information back semi-real time to GPs about what's going around. And by knowing what's going around helps them to make a sort of a value judgment about, you know, the cause of, you know, otitis media or other things that are coming their way. And remembering in general practice, it's a lot about the paediatricians at one end and then the elderly in the other end. They're the two big cohorts where there's a lot of use.
And then in terms of thinking about the nurse role and thinking about our panelists who are practicing as clinical nurses now in different settings, how would we think about advocating that antibiotics may not be needed for a viral infection? How would we start that discussion?
Well, I think, I mean, I've always said, always say this, I'm blue in the face, nurses are the coordinators of care, and it's often a nurse that the patient first has contact with, particularly in the primary care setting. And so allowing them some more empower them to have those discussions, I think is actually really important, and no more, you know, so important. I'm sure Noleen has talked about this in aged care. Having some nice, clear documentation, clinical pathways, like we've done with the nurse-led clinical pathways for sepsis, allows nurses to be empowered to help. And then building out, and I don't know whether you talked about the ACT framework, Fiona, at all. So when we talk about implementation challenges, often everyone wants guidelines. We have a guideline for this, we have a guideline for sepsis, we have a guideline for pneumonia, we have a guideline for bacteremia, we have a guideline this, that. There is a concept in implementation science which is really about making sure that whatever guideline is developed in your hospital, that it clearly states who does what. So what is the role of the nurse in the workup of a patient who's presenting with infection? Exactly what do they need to do? What do the doctors do? Sepsis, this is, you know, something that Alison's looking at when at the moment looking at the international national sepsis pathways to see whether that's clearly documented. Because if you aren't clear who the actors are, then who does it? So nurses, I think part of this issue, Fiona, is about very, very clearly defining what the scope of practice is for nurses, both junior and senior, and then advanced practice and nurse practitioner. Because I think that sets because the groups like pharmacists, for example, are very, very, very clearly defined scope of practice, I think.
Yeah, I agree, Kaz. I think, you know, sort of clearly defining the roles and clear pathways as well for common presentations we have is very useful. I mean, in the UK, through our, I think it's hospital in the home here, but our outpatient antimicrobial referrals, we had a number of referrals with sort of red leg, if you like, query cellulitis. And of course, there's numerous causes, you know, many of which are non-infective, you know, lymphedema and venous eczema and things like that. And that was led by two of the nursing team, actually. And, you know, I think doctors on hand, obviously, to venture an opinion, but it worked very well, actually. And I think there's no reason that can't be brought out into other conditions.
If I can just speak to aged care, knowing that we've had a lot of aged care nurses attend today, which is fantastic. Aligned with the new proposed accreditation or the quality standards, I think don't forget we need to really bring on board the residents if appropriate, and their carers and families. So some effort will go a long way bringing them on board.
And I think that in many ways, Noleen and Stephen, you work with a lot of the rural hospitals and more remote hospitals, so you may have a comment here as well. Part of the thing about thinking the clinical care standard is that issue of patient and consumer education, and just telling people, you know, if someone says, oh, I think I might need antibiotics, taking that opportunity to talk to people and educate them.
Yeah, and Noleen, just while you're here and you commented on aged care, there was a question earlier about antifungal use and how it's captured in the ACNAPs. If you want to comment on antifungal use in aged care based on, you know, your results from the ACNAPs, that would be great as well. Yeah.
Thank you, Arjun. So we are finding particularly clotrimazole is being used widely for, we're yet to dig deep, but the aged care NAPS is certainly suggesting for a lot of unspecified skin conditions. So our concern is as simple as, you know, somebody's got redness, that a PRN order is written and, you know, these, like clotrimazole, is being applied ad hoc. So an area for improvement, certainly. So thanks, Arjun, for the opportunity to, you know, speak to that. That's coming through consistently with our aged care NAPS results.
And I might say, Noleen, I don't think I introduced you any
That's
stage
true.
during
was
the
a comment.
workshop.
Oh,
Just a random that's turned up.
So just letting everybody know that Associate Professor Noleen Bennett is a project officer and she's senior infection control consultant with the VICNIS, with the Centre for Antimicrobial Stewardship and also the VICNIS Coordinating Centre in Victoria, and has been working in this space of AMS and particularly in aged care for quite a while. So great to have you here.
Fiona, if I can just have just to plug the aged care session on Thursday, I'll see it's in the link. Thanks, Courtney. But to the aged care nurses online, I think you would find that session beneficial too. So. And
Arjun, there was one more question or comment?
yeah, just one more comment from Sharon. She said clotrimazole is often prescribed, but not as often used. Just while I've got the questions open, there were a few people who had their hands up. Like Fiona mentioned at the start, if you'd like to verbally ask your questions or comments, feel free to raise your hands now, because I will be able to help you with that. Otherwise, continue to put your questions into the Q&A box. And thank you for the wonderful questions that have come through so far.
I am noticing.
I don't see any raised hands, so Fiona, you can continue.
I'm just noticing the time, and I have to say thank you to
You've just frozen, Fiona.
time. Back?
Yeah.
Do I unfreeze?
Yeah.
And it's survived all this time and just in the last minute. Thank you very much to all of you who've stayed on, is what I was saying, until the end of the day. We've very much enjoyed presenting this program. As I think has said, I'm actually just going to pop a little... No, I'm not going to do that because it's not working as it should. I was going to put up a little logo with showing, as it did on our program, all of the organisations that were represented in this workshop this afternoon. But look, you know, a workshop like this doesn't come together without work and a lot of collaboration from a lot of people. And as I mentioned earlier today, from a multidisciplinary team. So it's been very wonderful to have this group presenting, and we've had a few shows of applause coming up in the reactions while I've been talking, so thank you for that. And thank you also for your time and your contribution this afternoon. As Kaz mentioned, please do send questions to us to the central email address at the NCAS. If you're looking for a specific person and you don't have the email address, you can contact the NCAS central email and it will find one of us. And also on evaluation, you will be getting a thank you for attending message from Zoom at some point in the next 24 hours or so, and in that message there will be a link to an evaluation form. We would really love it if you would complete that for us and let us know your views on the workshop and what we might be able to think about doing more of or differently the next time around. But otherwise, I believe that's it, unless anyone would like to add anything.
I'd just like to say thank you to you, Fiona, for your massive effort in coordinating this.
Thanks, Alison.
Absolutely. Thank you, Fiona and team.
Thank you.
Amazing.
Thank you, everybody.
thanks, everyone.
All right. Okay. And on that note, we'll finish up the webinar. Thanks, everybody.
Thank you.